We are live.
Very good evening to one and all of you. This PG update has been coined to enhance the skill sets of postgraduates for their practical exams and more. And to make this thought into a real wonderful reality, we have the absolute top cream of expert panel to guide us along. We are lucky to have with us President AIOS, Dr. Mahipal Sachdev, who is to be joining us soon, our Honorary Secretary, Dr. Namrata Sharma, our eminent and most respected glaucomatologist, Dr. Ramakrishnan, heading the glaucoma department at Arvind Eye Hospital, Tirunelveli, our Honorary Treasurer, Dr. Rajesh Sinha, and all of them uh, who are going to be constituting the expert panel. And of course, Dr. Tanuj Dada, the leading glaucomatologist of the country and heading the RPC glaucoma department, are all going to be here with us today. I have with me Dr. Murlidhar, who's a senior consultant in the Eye Foundation group of hospitals, taking care of the pediatric ophthalmology, glaucoma, and neuro-ophthalmology, and Dr. Rohit Saxena, known to all of us, who's a member ARC North and is also a senior consultant in the pediatric and neuro-ophthalm at RP Center. And the two of them are going to be moderating along with me in this session. So you can be really sure that it's going to be a live wire session. Our first speaker of this session is Dr. Namrata Sharma, and she is going to be detailing us on the intro of tools in cataract surgery for greater precision. Yes, on to you, Dr. Namrata.
So thank you, Chitra, for inviting me today, and I would be talking to you about the image-guided tools in cataract surgery. There are no financial or proprietary disclosures. So basically, the image-guided tools help in cataract surgery for toric intraocular lens implantation, and then there is also intraop OCT, which helps you to do phacoemulsification. It just fine-tunes the step, and that is its function. So toric intraocular lens implantation can be done for astigmatism, and if it is with the rule astigmatism, then you do it for greater than 1 diopter, and if it is against the rule astigmatism, then you do it for greater than 0.75 diopter as well. After you've already done a good keratometry and axial length, depending upon the optical methods such as the IOL master, which we routinely use, one can do the toric intraocular lens implantation, and in the Alcon toric calculator, the toric axis as well as the toricity of the IOL which is required is calculated, and in the map it gives you where it should be placed. Now what normally happens is that if you do it manually, which is using the bubble marker, or if it is done manually even intraoperatively making the marks such as shown here, then there is some potential error which can creep in because of the head tilt or because of the smudginess of the marks that you do it here, or if the patient is uncooperative or fading of these marks can be there, and these marks may not be precise. So this is just to show the manual marking, how you can have smudges and then it may not be precise, and then there may be some parallax also which will be there. So the precise placement of the lens may not be, it may not be that precise or that accurate. So these are some of the problems of the manual marking system, hence the surgical guidance system in which you can preoperatively plan the case, do correct placement of IOLs, accurate alignment of toric IOLs, IOL positioning, and there's an opportunity to surgeon to see in real time intraoperatively all the alignments which are happening. So we have experience with Verion image guided system as well as the Zeiss Callisto Eye and Z line, as well as the intraoperative abrometry, which is the ORA. This is the Verion system, which has a Verion reference unit, which has got a measurement module and a vision planner and Verion digital marker. So pre-op registration can be done, and this is then imported on for into the machine for the data capture, which is done pre-operatively itself. Uh, this is how the incisions are seen intraoperatively. So you can see where you have to make the main incision, the side port incision. It gives you where your lens intraoperatively would be aligned. And it also helps you to mark the capsulorhexis so that the size of the capsulorhexis can be titrated, especially for the premium intraocular lens, and also helps you in the centration of the lens. Then this is the iOS axis alignment, which can also be tested with this. The second system that we have is the Callisto Eye Software system, which again has a reference image which is imported in the toric intraocular lens alignment system. and the reference image is matched and tracked by the limbal eye vessels to depict the desired axis. Again, this is taken into this is the reference image viewing, and then the limbal vasculature acts as a reference landmark, which is matched and tracked. Now, this is just to show a case, a live case of the same. So you can do the side port, you can do the main wound looking at this. Then one can do the staging of the rexes, as well as the rexes also can be made. And then subsequently the nuclear emulsification can be done. And this is the intraocular microscope, in fact, in which the intraocular lenses can be placed. And this is the marking, the Callisto marking. And as you place the lens intraoperatively, you can see actually the axis where the lens is going to be placed. And this axis comes, and this is, for instance, 109 degree here. So it can be aligned looking at this axis, which comes intraoperatively. And then viscoelastic aspiration can be done, and subsequently, again, the axis can be confirmed at the end of the surgery. So if there is a little bit of misalignment, then that can be titrated likewise. Now, again, you have an intraoperative aberrometry, and this is the Optiwave refractive analysis, which has a real-time assessment of, gives you the real-time assessment of the phakic, the aphakic, and the pseudophakic refraction, and it gives you a continuous feedback for toric IOL implantation again. Now, this is just to show how it works. So, this is the optical aura, which is by Alcon with no financial interest in it. So it calculates the power. Then there is this basket which is there, and when you put the lens inside, actually it will keep telling you which side to rotate. So you put the lens, so it is telling you to rotate on the other direction. So this blue arrow also tells you whether to rotate counterclockwise or clockwise. And then you have to get that whole central part into the basket. So this tells you, when you get this NRR, which means that no rotation is required. That means you've reached the endpoint and you are there. So what we do is that we do a combination technique. So we use both Aura as well as we use Verion to do the toric intraocular lens implantation. So a combined combined technique of Verion and Aura can be used. So again, this is just to highlight that the endpoint is a no rotation required. This NRR you are supposed to get. And it basically does aphakic refraction, calculates the IOL power, even the power it will tell you whether it is accurate or not, and also the alignment axis. Then uh, you have post-operatively also image guided systems like iTrace, which can tell you whether the IOL is aligned in the post-operative period or not. And then even if there are slight misalignments, these can be tackled. And this is the one that I was talking about, the combined Verion and Aura. So we do, with the help of the Verion, the incisions, the side port, the rexes, which was previously mentioned. And then with the Verion also, we try and align the IOL power, and also with the Aura, just to match it. So for instance, in this case, again, it is showing that there is some amount of astigmatism and some amount of spherical error which is there, and we'll have to change our lens. So we change the lens to get more cylinder, and again align it onto the axis which is shown, and then also confirm it with the Aura. So this green thing has to come inside this green basket, and when that thing comes, then you know that you are completely focused. And again, the endpoint will be something like this, no rotation required. So we've confirmed on 2 instruments now. And I think this is the last bit, which to show that side port, main wound, the capsular rexes, etc., all can be imaged on this intraop OCT, which is present. And this comes in the same surgical field, both this as well as this. So the flap is elevated. So you can see the flap is elevated here. If there's a corneal haze, then you can see the flap elevated through that corneal haze. Then this is the rexes. So this hydrodissection wave can be seen here as well. And likewise, when you are hydrating the wounds, then you can make out whether the wounds are completely closed or not. If there's a posterior polar cataract, you can actually see whether there's a gap which is present here or not. And then if you have a white cataract like this, you can see that there are some fluid spaces. So if these clefts are there, that means when you give a nick in the capsular rexes, no fluid is going to come out. So you may not have an Argentinian flap. But if you have a white cataract, which has got a raised intraocular pressure such as this, see, there are no fluid clefts at all. So as soon as you give a nick, the liquid cortex is going to come out. So you can predict these kind of things which we earlier couldn't by the use of the intraop OCT microscope. So image guided systems do have some kind of limitations, because you there should be no conjunctival ballooning, emotion should not be there, patient should be cooperative. In case of deep set eyes, it may be a problem, or even in cases of narrow palpable apertures. So, to conclude, intraoperative tools have a role to play in cataract surgery, and they help to fine tune the steps of the cataract surgery. And the tools and the techniques are getting modified, and over a period of time, I think they will get more, there'll be more fine tuning into it, and it will get only better. Thank you very much for your kind attention.
Thank you very much, Dr. Namrata. I just one very basic question I wanted to ask. Now that you have access to all these gadgets, does that mean that you would no longer do a pre-operative astigmaticfix.com to find out? I mean, it shouldn't be that just because you have a sophisticated tool, you still do the old other ones and this also, and you add to the work, or would you straight go in, get to know intraop and then do it? How do you do it?
So I think the basic tools that we have are most important, because they've stood the test of the time and stood the track record of so many years. So they would still be there as a basic workup. And these tools can only fine tune your surgery, and also in some of the complicated cases like post LASIK cataracts, where you need to get the IOL part exactly there, they may help. So they may help you in complex situations, or you have very high cylinders there, they can help. And also they can help you to fine tune your surgery. So that is the advantage of these tools.
Madam, is the aura
Uh,
chargeable on a per patient basis, or is it?
Aura is not chargeable at all. The initial cost is only of the machine that you buy, and then the patient doesn't have to pay anything for the Verion or for the Aura. I mean, at least in the government setup, I'm sure because it would have costed something, so it must be charged extra in the private setups. I'm not aware of that, but for us, once we are doing this, then there is no extra cost to the patient.
Madam, any pre-operative data also you have to input into the aura?
So yeah, so in the Aura you have to put put the pre-operative data, pre-operative keratometry, exit length, everything, and then calculate the power of the lens, and then you feed that data into the Aura. And once the patient becomes aphakic, that means you've already done a irrigation aspiration, and your bag is ready for an intraocular lens implantation. You do a aphakic refraction, and then it will give you some power of the lens, and then you check whether the power that you had got from your biometry, from your IOL master, etc., and the keratometry that you had done in excellent, is it matching with the aura power or not? And then you again take a call. For instance, if it is a toric IOL, sometimes it will tell you higher cylinder than what is required. Sometimes it will tell you lower cylinder than what is required. So you titrate accordingly. So Aura can help you to titrate the powers intraoperatively. So we like to keep 2 or 3 backup lenses. So suppose you're doing a toric IOL and if the Aura tells you do T6 and not, T9 or whatever. So we will change our decision on the table and change the lens.
If you inject more visco after the cataract surgery is over, madam, will it influence the aura calculation? I mean, depending on.
So for Aura, this is a little bit of flip side, that every time you have to keep the chamber tight. So when you're doing an aphakic refraction, you have to put a lot of viscoelastic there. You have to just fill it up with Helon and then do the refraction and put a IOL. And after putting the IOL again, the chamber has to be absolutely tight. So some people like to put viscoelastic, or some people like to put BSS to make the chamber tight. So this is of course there, and it takes a little more time as it would in normal cases, because you need to check and counter check.
Actually, intraopacity, you could even know that the PPC, the PC is likely to give away, and you are able to deal with that. But Dr. Rajesh Sinha, can you tell us what would be its role in lamellar keratoplasty? Intraopacity?
IOCT?
Yes.
Yeah, actually, in lamellar keratoplasty, IOCT is really very useful, because you get to know first for a posterior laminar keratoplasty, let me first tell you, like when you do a dissect procedure, when you have implanted the lenticule and injected air, you get to know whether fluid is there between the donor lenticule and the cornea or not. So if there's no fluid, this means that's the end point. You don't have to inject more air and wait for some time so that the lenticule are there, and then you can reduce the amount of air. Similarly, for DMEC also, you get to know what is the orientation of the lenticule, and that will give you the idea of whether the lenticule is in the correct orientation or not. For anterior laminar keratoplasty, again, when you are dissecting, you get to know at what depth you are dissecting. When you are dissecting, it doesn't give you live like, below the instrument with which you are dissecting. But when you lift the tissue, you get to know that how much tissue is left behind. And further, it also helps you to have a uniform stroma all around. Because sometimes what happens that you get a slightly thinner stromal bed on one side, a thicker on the other side. So in that case, the patient might be having some, visual issues after that, or optical issues after that. So you would like to have a uniform bed. So if it's a thicker on one side, then you can go ahead. Further, you also know that how much deep you have gone in, because there's always a risk of perforation when you are doing a layer by layer dissection. So IOCT, gives you, we call it, it's a third eye, which gives you an idea that at what position, at what layer, at what level you are working. So it's a good tool. It's really a good tool for laminar keratoplasty.
Any other questions from the expert panel?
If I might. Thank you, Dr. Ramarada, for the nice talk. Can you give some tips, even with the careful placement and the careful variants? Sometimes you have some rotation post-operatively. Can you give some tips to give how to prevent the
Dr. Namrata?
So yeah. So just to give some tips of how on Verion you can prevent rotation. When you put the when you are there are times when there is a mismatch between the Verion and between the aura. So it should be, and there might be some amount of parallax also. So even if one side of it aligns, it is good enough. The other may not be completely bang on because of the parallax that is present, because of the differences in the anterior chamber depth that is created. So even if one side, kind of aligns, it is good enough. The other side will fall in place.
My take on this is that, there are two parallel lines which are adjacent to it. As far as both the notches or the markings on the lens are aligned to that, parallel to it, it's okay. It should not be that one is aligned and one is not. But usually, if it is within those dotted lines, then generally it works well. Another just a question. One thing is that, there is definite click fee as far as aura is involved. At least we guys have been told that, and that's the reason we are keeping away from it. And maybe it's not being charged at your institute. And secondly, as far as the interest in aura itself is concerned, it's slightly waning now, in the sense that studies have emerged, especially with the latest generation optical biometers, the formulae that are available. And if alignment based on the aura is done on the table, there are studies which have shown that the results might have been better if they're stuck to the initial readings that was obtained with the optical biometers using the latest formula, rather than correcting on the table. It has worked both ways. David Chang has presented on this quite extensively. So I think that's one of the reasons that the aura is not really taking on as well as it was expected to initially. Your comments on this?
Dr. Namrata? Namrata, are you connected?
Actually, aura, or what I also felt that aura does have a little bit of some element of error sometimes when you have not injected the viscoelastic properly in the anterior chamber. It's not tight. Then in that case also you can get, you do have some element of error. That is one thing I have felt. And of course, apart from that, it's a way to fine tune things, but there are other ways as well. I mean, that's what we can say.
Okay.
So what all measurements does the aura take? Does it remeasure the axial length and keratometry, or just the aberration? And
it's basically on based on aberrations. So finally, it's based on the aberrations and the refract. It's the name itself suggests. So it's basically on the refraction and the aberrations that gives you an idea that what is the power that is deficient, and how much power will add to take care of it. So I mean, perhaps that's the way it works. It basically works on aberrations only.
Thank you very much, Dr. Rajesh. Welcome, Dr. Mahipal.
Thank you.
Dr. Rohit, would you like to introduce the next speaker?
So, pleasure to introduce the next speaker, Dr. D. Ramamurthy from the Eye Foundation, Coimbatore, an outstanding speaker and whose clear, lucid presentations, particularly on biometry, are much sought after. So he'll be talking on optical and immersion biometry in cataract. Dr. Ramamurthy.
Thank you, Rajesh, and thanks ARC for this kind invitation. I'll be essentially, for reasons of time, covering on aspects of optical biometry. Refractive cataract surgery has become the mantra today, and though significant advances have been made in intraocular lens technology as well as extractive technology as far as phacoemulsification machines are concerned, it's a classical case of garbage in and garbage out. So getting your measurements right is extremely important, and that's where optical biometry comes to play a very important role. As far as this presentation is concerned, I have no financial disclosure. There are three types of optical biometers I am conversant with, which we are using in our different centers, the AIOS-Master 500, 900, and 700. I must also say that we are spoiled for choice today. There are several other excellent biometers that are available, and you have to pick and choose. Many of them have the modern intraocular lens formulae incorporated in them, very good features. So if at all you are looking for purchasing one of these, you need to do a significant amount of research before coming on to what exactly you want to work with. My experience have been largely with AIOS-Master 500 initially, which was based upon A-scan biometer, and it was the first optical biometer that became available. Today, almost we are completely shifted over to the AIOS-Master 700, which is based upon the Swepsos OCT, and it's essentially a series of B-scan biometers. Biometry that's taking place. There are more than 2,000 scans per second that's measured with the Swepsos OCT, and the scanning is done at 0 degrees, 30 degrees, 60 degrees, 90, 120, 150. So it gives a multi-dimensional view of the entire eye, right from the corneal epithelium to the retinal pigment epithelium, and this is essentially analyzed by the software, the instrument, to give us all the data that's required. One of the major differences between the AIOS-Master 500 and 700, and the 700 shares these features along with the Lenstar 900, is that it gives information about both the corneal thickness and the lens thickness. And this essentially becomes important when you're dealing with the latest generation formula like the Barrett or the Baylor nomogram, or even the Holiday 2, where 7 or 5 different features are required compared to the earlier regression formula that we used to use. So essentially, that's the reason that these biometers work very well integrated with these modern generation formula. Because of the Swepsos OCT and the B-scan biometry, which is integrated, both the corneal measurement as well as the lens thickness is something that's reliably reproduced by these two instruments. We look a little deeply into these features. When it was the AIOS-Master 500, here again the patient had to look at directly at the red light, and that's the reason that we thought that it is most often concentrated on the visual axis. But in case the patient looks away, then the instrument measures a different part of the eye, and there was no objective way of checking whether the patient is focusing on through the fovea or is looking away at the time of taking the measurement. On the other hand, with the AIOS-Master 700, you have the fixation check or the retina scan, and basically we make sure that when the patient, at the point of measurement, the light is falling on the foveal pit in case it is not on the foveal pit, then you know that it's going to be inaccurate measurement. Just to illustrate this point with a couple of examples, you see two measurements which are both are being taken at the foveal pit exactly where it should be ideally done. So this translates into just a 0.02 diopters of difference in the keratometry. And as far as the axial length is concerned, again, you find that it's just about a 10 micron difference. And that's the reason that you'd find that when it comes to intraocular lens power calculation, two subsequent measures almost give you exactly the spherical power and cylindrical error. And that's the reason that having this ability to objectively cross-check whether the patient is focusing rightly is an extremely important feature with the IOL-Master 700. When it's not so, as you can see in this case, you do not see the foveal impression. It's poor fixation of the patient, which can be detected by the examiner. And you see that there's almost a 0.5 diopter of difference in the keratometry and 190 micron difference in the axial length. And obviously, it translates to an error of almost a diopter as far as the spherical power is concerned, and again about a 0.5 diopters as far as the cylindrical error is concerned. So because we are able to objectively verify whether the fixation is on the fovea, it ensures that the intraocular lens power calculation is quite accurate. It also acts as an OCT as far as the posterior in the area of the macula is concerned. A feature like a macular hole, a dry IRMD, you can see some drusenoids over here, a diabetic maculopathy, epiretinal membrane where you see sharp image right in front of the pigment epithelium. Obviously, this is not a replacement for a conventional OCT that our retina colleagues use, but it tells you immediately, this warns you that something is wrong with the retina, and maybe a retinal consult is extremely important before going ahead with the surgery in these cases, so as to avoid the suboptimal outcome in the postoperative period. There was no significant instrument that was available to us as far as the AC depth was concerned in the postoperative period. But here you can see this is with the lens and this is with the pseudophakic lens. And you can see the precision with which the AC depth as well as the effective lens position can be measured with this particular instrument. It also gives us an idea about the lens tilt. Most often, both the natural lens as well as the pseudophakic lens that we place is tilted a little nasally. And this is supposed to have an impact as far as the astigmatic outcome is concerned. And work is on to incorporate this as far as the exact orientation of our intraocular lenses is concerned in the toric intraocular lenses. This is work in progress, but suffice it to say that if a significant tilt is noticed, then these cases may be ruled out for premium intraocular lenses. This is a study which showed that with the IOL-Master 700, the repeatability of axial length measurements is in the range of about just 9 microns. And with the IOL-Master 500, it's 500 microns. With LensStar, it's again ranges between 20 to 35 microns, which is almost 1/10 of the error that you could get with the immersion A scan. And that's the reason that these instruments work very accurately. And another important feature, because of the Swepsos OCT feature with the IOL-Master 700, almost the densest of cataract, whether it's a posterior subcapsular cataract or a total cataract that you see over here, or even a post-polar cataract, even a mild vitreous hemorrhage, you are able to get a good repeatable IOL power measurement, which was essentially not possible with some of the earlier instruments. Even with the IOL-Master 500, it used to be that about 28% of the cases, you're not able to get a reliable measurement, and so you had to resort to immersion A scan, which is again well handled, gives you fairly reliable measurements. As far as the keratometry is concerned, which is again an important feature because of which axial length and the IOL power calculation could go wrong. There were just about 6 points that was measured with the IOL-Master 500. With the LensStar, it was 32 points. But with the 3-zone keratometry that's incorporated with the IOL-Master 700, these are 18 points that are measured at 1.5 millimeter, 2.5 millimeter, and 3.5 millimeter. And this gives you an excellent idea about the keratometry. And I find that I have virtually given up doing an auto K or a manual keratometry in these cases and go by the keratometry readings that are given by this particular instrument. The telecentric keratometry is again an important feature. What exactly do you mean by that? Is that the patient could be a little uncooperative, could be moving his head backward or forward. The technician may not be absolutely experienced, because of which the spots of light that you see may not be exactly in focus, but the distance between these spots do not vary, because of which, irrespective of the device to eye distance, the keratometry readings that you get are extremely precise and repeatable, and that's an extremely important feature as far as telecentric keratometry is concerned. We all know from our knowledge of toric intraocular lenses, especially, that the posterior corneal curvature measurement is extremely important. It was possible, it's in Scheimpflug image instruments like the Galilei or the Pentacam, but it was found that it was not totally correlated with the toric intraocular lenses with the formula like with the Barrett or the Baylor. Now with the AIOS-Master 700, because of the OCT principles, you are able to measure the anterior corneal curvature very precisely, and then get an idea of the corneal thickness, because of which you are able to exactly arrive at the posterior corneal curvature, and because of which you get a posterior torus fit, which is incorporated in the formula that is available for the intraocular lens power calculation. That's the reason that the AIOS-Master 700 gives you all these readings. That is the keratometry, which is essentially from the anterior cornea, the posterior keratometry, and the total keratometry, which incorporates values of both these. And these are the intraocular lens power calculations based just upon keratometry or the total keratometry. Sometimes they correlate, but sometimes, as you see in this case, there's almost a 0.5 diopter difference. This is not just in the toric measurement of the toricity, but even, as you can see in this case, even in the spherical power calculation, there could be a difference. More importantly, it does not require any big change as far as your intraocular lens power calculation is concerned. You could incorporate the measurement that is taken with a conventional modern generation formula that you're kind of normally using, or even the ULIP constants, and then go ahead with your intraocular lens power calculation. And again, specific formula that are used with this AIOS-Master 700 has become available. Now the Barrett comes with the Barrett TK Universal 2, which is essentially used for the calculation of the spherical intraocular lens, and the Barrett TK Toric for the toric intraocular lens power as well as this orientation. Now we have also the Barrett True K Toric formula, which is essentially used for the intraocular lens power after a post-refractive surgery scenario. Because of the exact measurement of the anterior curvature and the posterior curvature, the specificity as well as the precision of these formulas is significantly enhanced. Whether it's the Haggis or the Barrett that's used, incorporating the actual measurement of the posterior corneal curvature, whether you have a cutoff of a 0.5 diopters or a 0.75 diopters or a 1 diopter difference in the toric IOL power calculation, you find there is a significant improvement when you actually measure compared to what is mathematically assumed in the older Barrett formula. And again, we all know that when it comes to post-refractive surgery scenario, because of the change in the alignment between the anterior corneal curvature and the posterior corneal curvature, it becomes quite a challenge. Today, because of the precise measurement of the posterior corneal curvature, these studies which have just come out in the April 2020 issue has shown that the measurement, the accuracy of the intraocular lens power calculation, especially for toric intraocular lenses, becomes significantly enhanced. With the availability of the AIOS-Master 700, our very workflow has changed in the sense today, once the patient goes in for a cataract surgery, the first measurement that we do is a toric measurement using this formula. And when we see the TK is about 1.26 diopter, then automatically, whether the patient is opting for a monofocal or a multifocal, the conversation shifts towards a toric monofocal or a toric multifocal so as to achieve emmetropia for all distances. Again, this instrument also gives you an idea about angle alpha and angle kappa. Angle alpha is relatively more important when it comes to intraocular lens implantation. When anything beyond 0.5 millimeters, we tend to keep away from premium intraocular lenses. This value has become a little questionable of late. I personally keep the cutoff value as 0.7 millimeters. Angle kalpa is more useful as far as keratorefractive surgery is concerned, because here you are measuring the difference between the center of the pupil and the visual axis, while in your intraocular lenses are more aligned depending on the limbus, and that's the reason the angle alpha is more important. So along with improvement in intraocular lens technology and the ability to extract intraocular lenses using the lasers as well as modern phacoemulsification systems, today we have excellent imaging systems incorporating the latest generation intraocular lens power calculations, so that it's a possibility to achieve emmetropia almost in 90 to 92% of the cases, irrespective of the power that you are dealing with or whether it's a post-refractive surgery scenario. Thank you so much for your kind attention.
Thank you very much for a very lucid talk, Dr. Ramurthy. I have just one question to ask. Now that we know that where we stand with IOL Master 700, do you say that immersion biometry needs to be put away into a dustbin, or with the newer formulas which we have, if you incorporate it, would it work nearly as well?
Absolutely. I think having immersion A scan is absolutely necessary. And as you know, among our centers, there are a few centers which still do immersion A scan, do multifocal intraocular lenses, toric intraocular lenses with good results. The only difference between an immersion A scan and a good optical biometer, I feel, is the optical biometer is relatively idiot-proof, in the sense that you could have a reasonably inexperienced technician or a patient who is not very cooperative and maybe a post-refractive surgery scenario, etc., and still get reliable data. But as far as if an immersion A scan is done by an experienced technician using all the right modalities, then it's possible to get quite good repeatable axial length as well as the keratometry readings. And again, they can go on to the APA-CRS, AACRS websites and get the benefit of the modern formula like the Barrett formula for their intraocular lens power calculation. So definitely, if you can afford it, a modern biometer like the IOL Master 700 or the Lenstar or something equivalent to that is good. In case you are thinking of upgrading to a better phaco machine, I would say that buying a biometer first before going on to upgrading your phaco machine, because with phaco emulsification, I strongly believe that technique is more important than technology itself. But if you don't have it, if you do immersion A scan well, you can again get very good results, and we are experiencing it in our own centers.
Sir, I have a question. Sir, for example, if you don't have access to IOL 700 and you can't calculate the posterior corneal astigmatism, and you opt for the option of the predicted posterior corneal astigmatism in the IOL power calculation formula, so is it okay, or should we, just don't even include the posterior corneal astigmatism?
Absolutely. The thing is, the basic Barrett formula mathematically calculates and assumes a certain posterior corneal curvature based upon the anterior corneal measurement. So if you're not measuring it, you directly go on to Barrett Universal 2 or Barrett TK or Barrett 2 TK and go ahead and do the calculations. And it's only when you are actually measuring using something like IOL Master 700 when the TK variant comes in. So you cannot combine both. You cannot measure it and again use a formula which mathematically assumes the posterior corneal curvature. So you have to pick and choose whether you are going to use the simple Barrett formula or the Barrett TK formula, depending upon which biometer that you are using.
And one more question, sir, that if you are using these like IOL Masters or Lenstar, so then the role of keratometry, or, if we were talking about topography, that's totally out. We don't need to do any we'll just rely on the keratometry readings which have come from the biometer.
Almost 4 to 5 years, till about 3 to 4 years, I used to love my a manual keratometer. That was the case almost for 3 decades. But today, I believe the technology is progressed to an extent where your optical keratometers, good autokeratometers give you extremely reliable readings, and definitely I would any day go by them than a manual keratometer.
Ram, one question.
Yes,
Sorry,
yes.
one question, Ram. We always talk about the main two companies, and that is the IOL Master and the Lenstar. But for a normal person, where there is a cost, because today if you look at an IOL Master 700, that's 30, 35 plus or whatever it is, and the advanced version of Lenstar is also 20 to 25 or whatever it is. There are other companies who also provide, for example, you have the Aladdin, you have the Nidec, you have the Tomy, etc. So from a common practitioner's perspective, I fully agree with you that the immersion is very much there and you still will need it, and it's a good thing. And even when you're using a IOL Master 700 with the swept source, you are still having some patients where you can't get the axial lens, so you will still be needing that. So what I'm asking is, if we compare with these other biometers that are available, and now recently I'm looking at one OCT angio from Hewitts, which by just an addition of 1 lakh rupees, they will also give you the biometer. Because after all, if you look at it, it is the measurement when you're doing the OCT, you're going to the retina and then it's coming back, so you can measure from there. The only thing is so the second part is the formulas. Just leave the formulas apart, but the measurements that you get on the other ones, how accurate are they, or would they suffice in say 95%, 99% of the cases for a private practitioner, or he still needs to go for these upper end biometers?
I cannot agree more with you, Maipal. Actually, this was my opening statement, in the sense that, my experience with IOL Master 700, 500 and Lenstar, but there are other good equipments available, and you definitely need to look into it. We ourselves have two more recently bought two Tomy biometers, and I think all these are good instruments. The top one itself has the Barrett, and leave alone, even the formula is incorporated in many of these biometers, and they're also quite precise. It's definitely having a look at them. So I was talking from my personal experience, but it's extremely important that cost is a consideration, and IOL Master 700 definitely is beyond the reach of many. So that does not mean that they do not go on to an optical biometer, and there are other excellent alternatives available, incorporating the modern formula also. And it's and many of them would even give you a demo. You can keep them for 10-15 days in your center, test it out, and then talk to others like Maipal who have experience with their instruments. I definitely do not recommend that these are the only instruments you go with. It's good that we have the freedom of choice and the ability to pick and choose what we need.
Yeah, because I have the experience personally. Personally means in our centers of the Tomy plus the Nidec, and I have not had any complaints from those centers where we have kept them. So it's worth, as you were saying, it's worth the individuals trying that out, because the costings are reasonably different between the two. Yes, the angle measurement, alpha, kappa, etc. How much of value that is, that one has to see. But I think that's the point that I wanted to make, that there are alternatives to the best.
I think one other important thing is each of us have to spend time to understand the capability of our equipments, whether it's a pentacam or a biometer or anything, or even a Verion. When you start preparing for a talk, you really realize the capabilities of these machines. Very often it's a optometrist who has taken the readings and you just go by it. But then when you do a deep dive into it, you find that so much is available, and most of these equipments will give you fairly reliable readings. I think it's important that we spend time understanding them.
Yes.
Murli, you have anything to ask, or shall we move on to the next speaker?
I have one question, sir, for the PGs. What is different in the IOL Master 700 that it is able to do axial length measurements in dense cataracts, whereas other biometers are unable to penetrate?
I think it's a
basically, you tend to think that IOL Master 700 is just an upgrade over IOL Master 500. Actually, these are two completely different instruments. This uses a swept source OCT, while that is based upon different principles, and even the LensStar uses optical low coherence reflectometry. All these are, and IOL Master 500 uses the PCI, partial coherence interferometry. So because of the sweptososity, this gives it the ability. For example, since you asked me, why is it called sweptos? Because the average wavelength is supposed to be 1060 nanometers, but it's varying between 1050 to 1070 nanometers. I don't really understand the exact physical principles. It is because of this capability that it is able to penetrate through almost 98% of the media and give you a fairly reliable readings.
The technology is different.
Yeah.
Thank you. We shall now go on to our third speaker, Dr. Parul Soni, another eminent glaucomatologist. And she is going to tell us something very essential, how to read a visual field printout.
Thank you, ma'am. Thank you, AIOS, and thank you, Dr. Chitra, for having me here. After listening about the IL power calculation and the toric calculation, let's now jump on to the glaucoma, and I will be talking about that. How do we read a glaucoma printout? And I think all of you would agree that automated perimetry is currently gold standard for diagnosing the visual field defect, and it's one of the very important tests in glaucoma diagnosis. And it stands tall not only on the shoulders of an art of good interpretation of the visual field, but also at the same time, what is important is art of doing the visual field. I won't be going into the details, but whenever we are ordering a field, we should ensure that what is the type of strategy that we are ordering for that particular patient. And before we start a field, we should explain the patient that what we are going to do, make the patient comfortable, and support and monitoring him throughout the test so that we can have a very good outcome and a reliable visual field. So whenever we have a visual field printout in our hand, what are the questions that we need to answer? Number one, we need to know what is the strategy that is being used. Secondly, is the test reliable? Is there any defect present? And if the defect is present, is it a glaucomatous or not? And whenever we are following up a patient of glaucoma, is the defect progressing or not? So I'll be quickly answering these questions. And there's a very good article which was published by Dr. Ravi Thomas, which was published in IGO in year 2001, which talks beautifully about how do we read the printout by dividing it into different zones so that we don't miss upon any of the important areas presented on the visual field printout. So this is how we can divide the visual field printout into different 8 zones, and I'll be quickly running through each of these. Now, the first zone tells you about 3 important things. It tells you about the patient data, the name and the age of the patient. It also tells you about the visual acuity, what is the pupillary size and whether we have put the correct refractive lens correction or not. And it also tells you about the type of strategy used, the fixation target size, and what is the type of target used. So we can choose from different strategies. Presently, we are mostly using SITA strategy, which is Swedish interactive testing algorithm, which is much faster. And now we have the SITA faster also, which is almost 25 to 50 times faster than the SITA fast technology. Then we can have different patterns, which could be depending on the type of glaucomatous damage that patient has. You can choose a 30-2 or a 24-2. If patients have advanced glaucoma, then one can opt for a 10-2 or a macular test. The pupillary size is again very important. If patients who have who are on pilocarpine or who have senile meiosis if the pupil is 1 millimeter or smaller in size, you can have a artificial field defect, which can look something like this, something like a rim artifact. So when you do the test by dilating the pupil, the field defect disappears. So pupillary size is very important. Now moving on to the second zone, which is again of a lot of importance, which tells you about the reliability indices of the visual field. It talks about the fixation losses, the false positive and the false negatives. It also tells you about the test duration and whether you have kept the fovea on or off. Now, how does the machine monitor the fixation target? It projects the stimulus on the blind spot, and if the patient is pressing the trigger, that is noted as the fixation losses. And you can also, the perimetrist can also see if the eye is moving on this window. And there's another thing which is called gaze tracking, which is again done by projecting a small infrared focus on the center of pupil. So if the center of the pupil is coinciding with the gaze tracker, the line comes out straight and with minimum deviations like this. But if the patient is having a lot of movements, you can see a lot of black spikes up and down. So in such a case, you better repeat the test to get a better reliable visual field. Now, other thing is false positive errors. Sometimes what happens, patients are very anxious and they continue to press the trigger despite the fact that there is no projection of any stimulus. In such a case, the machine labels the fixation false positive errors if they are more than 20%, and they are flagged as double cross in a CETA standard. And if they are more than 33% in a full threshold, then they are double flagged as double crosses. In such a case, again, you have to repeat the test. Another important thing is a false negative error. Now, this happens when the patient is supposed to respond to a stimulus, but he does not press the trigger. Now, this could happen if the patient is very tired. So if the patient has been waiting for a very long time and then you take him for a field, you can have something like a clover leaf type of a field, in which you can see in the center part, the patient is doing very well, but as the field is progressing, the duration is progressing, the patient loses the attention, and you can have a lot of artificial blind spots. So again, this is tagged as double cross if they are more than 20%. So whenever you have a field printout in which these reliability parameters are flagged, you have to read that with a lot of caution. Ideal is to repeat the test, but one has to remember that in advanced glaucoma patients, sometimes you can have high false negatives and still a reliable field. So you have to take into consideration the clinical picture in that particular patient. Now, moving on to the zone 3, which is the gray scale. Now, gray scale is something which tells you about the field loss or scotomas at a glance, but this is good for explaining to the patient. It should not be used in isolation. Another important zone is the total deviation zone, which tells you about the loss of the retinal sensitivity as compared to the age-matched normal, which is incorporated in the normative database of the machine. So it tells you about the generalized elevation or depression of the field, and it is presented both as the numbers or as the probability plot. But the most important thing in glaucoma patients is the pattern deviation plot. What the machine does, it eliminates the generalized elevation and the depression, and then it tells you about the localized scotomas. So if there is a generalized depression because of the presence of cataract or myotic pupil, that is taken care by the machine. Just to give you an example, for example, if a patient has scotoma like this, the machine will eliminate this depression and the focal scotoma gets more visibility. So similarly, if you have a patient of cataract, for example, like this, you have a lot of black spots in the total deviation, which are then eliminated. And you can see there is no scotoma on the field, on the pattern deviation plot. So the patient does not have any glaucomatous field. What he has is the generalized depression because of the cataract. Another important thing which is mentioned on the CETA printouts are the glaucoma hemifield test. Now, we all know that glaucoma is an asymmetric disease which has asymmetric involvement in the superior and inferior hemisphere. So these 5 areas are compared in the superior and inferior hemifield, and that is how the machine tells you whether the GHT is within normal limits or outside normal or borderline. The other important thing to be looked at in the field is the zone 7, which talks about the global indices. The important ones are the mean deviation and the pattern standard deviation. Now, mean deviation is the average of all the points on the total deviation plot. So if it is positive, that means the patient has a normal field. But if it is negative, the higher the negative values, the more depressed the field is. That means patient has high degree of glaucomatous field loss. And similarly, you have pattern standard deviation, which is again derived from the total deviation plot. This tells you about the localized scotomas. So higher the pattern standard deviation values, the more advanced the field defect is. So the important key points to remember are the mean deviation and the total deviation tells you about the generalized elevation or depression of the visual field. However, more important are pattern standard deviation and the pattern deviation plot, which tells you about the localized scotoma. Now, visual field index is something which is again very important. Now, this is a numerical value which is mentioned in terms of percentage. So if a patient has absolutely normal visual field, he has a VFI of 100%. The moment the visual field defects start to appear and the scotomas appear, there is decrease in the VFI index. So if, for example, this patient has a 75% of VFI index, that means almost a 25% of loss has already occurred. And this is very important number, which you can easily explain to the patient that this is how the visual field looks like. Now, sometimes all these deviation plots and pattern deviation plots are not very informative. In such a case, you can look at the numeric data, which tells you about the retinal sensitivity. And there are a lot of numbers which are given in brackets. These are the areas where the machine has tested these points twice. So these are the values which are repeated, and that's how you can compare the values and see where is the diminution in the retinal sensitivity as compared to the neighboring areas. So once we have detected that the patient has a field defect, we have to know whether it is glaucomatous or non-glaucomatous. Now we know that the glaucomatous field defects, very important thing is that you have to always correlate them with the optic nerve head finding, and clinical correlation is very important. So, and you can also use this Anderson-Patella classification to know what is the definition of glaucomatous field defect. And on a CETA printout, if you have an abnormal glaucoma hemifield test, if you have a PST which is less than 5% of the normal field, and if you have three non-edge points out of which 1 point is at least 1% of the lower probability than the normative database, and 2 points are less than 5%. If you have all these three criteria, they fit into the diagnosis of a glaucomatous field defect. So just to give you some examples, if you have an inferior notch, you can always correlate it clinically, and you see a superior field defect like this. You can have an early nasal step and a small little amount of wedge-shaped defects in the nerve fiber layer. Now, again, as I mentioned, the clinical correlation is very important. So if you have a field like this showing an inferior arcuate, if you do not correlate it clinically, you may think this is glaucomatous, but when you dilate and you see the patient has a superior BR view. So clinical correlation is very important. And also we should always remember that there is something like a learning curve. So when the patients do the test for the first time, they may not do it nicely. Just to give you an example, now this patient showed a superior arcuate scotoma, and when we repeated the test, the scotoma disappeared. So a learning curve is something which is very important. We should always repeat the test and we should have at least 1 or 2 tests to have a proper baseline. Now, again, you can classify based on the visual field defects, the glaucoma into an early defect in which the mean deviation is less than 6 decibel. You can have a moderate defect when the mean deviation is between 6 to 12 decibel. And if the mean deviation is more than 12 decibel, you have a severe defect. So this is how you can see on the visual field printouts, mild, moderate, and early defects. So once we have known that the patient has glaucomatous field defect, I won't be going into the details of progression. It is very important for us to know whether the disease is progressing or not. And I just want to mention that it is very important that we should not be comparing the apple with oranges. It is very, very important that we should be comparing the same strategy on the same machine. So if you're using a Humphrey, compare it on the Humphrey printouts. If you're using an Octopus, follow up the patient on the same program. And we can have different options. You can use an overview program. You can use glaucoma progression analysis. And that's how you can pick up progression in your glaucoma patients. So I would like to summarize by saying that whenever we are trying to read a printout, we should look at the strategy that has been used. We should see whether the field is reliable or not. We should try to identify if that the defect is glaucomatous or not. And lastly, but most importantly, we should know whether the defect is progressing or not. And at the end, the interpretation of visual field is not a child's play. We should always correlate it clinically, compare it with the optic nerve head findings and the OCT and the intraocular pressure to make a complete diagnosis. Thank you so much.
Thank you very much, Dr. Parul, for doing so much justice in 10 minutes to this talk. I have a question to Dr. Amanjeet or any of the expert panel. Now, with the advent of the low-cost perimeters which have come in and they have a limited normative database, what would your thoughts be on people buying them and using them? Dr. Ramanji?
Ma'am, unmute, please.
Hello?
Yeah. Hello, can you hear me?
Yes.
Yeah.
Yeah.
Okay, so the question itself was the answer that, the normative data is absolutely important. The number of people that are put in, the kind of people that have been put in is extremely important for you to be able to rely on looking at the perimetry printout, whether it's Octopus or Humphrey or any other printout, to say that this is actually abnormal. If you don't have enough normals that are there, you are not going to be able to say it's abnormal. And as Parul said, the first thing is to first figure out, is there anything abnormal? And if it is abnormal, is it neurological, is it retinal, is it glaucomatous? That becomes a secondary question. So they are much cheaper, but I keep trying to tell the companies to do a little bit more in terms of putting in better normative data. And also the software that actually post-processes is something that is now been added very significantly, both to the Octopus as well as the Humphrey. So it's not just what the patient is doing, it's also what has been fed into the software, which says that, this kind of abnormality in sort of 500 patients that the data actually has is likely to be a superior nasal step, or this is likely to be a arcuate scotoma. So there's a lot of post-processing that goes into all the algorithms that are now in these two big machines, the Octopus and the Humphrey.
Between the event-based and the trend-based analysis, which would you say is better, and if so, why?
The question is to me.
Yeah, you or to Dr. Tanuj? Or
I think the trend-based is important in that it tells you over time. So once you have 5 fields, then you're likely to be able to judge progression by either means. The trend only gives you an idea of what's likely to happen, while the event will actually pick up a change even in one point. The trend is an overall sort of visual field index and mean deviation kind of change, while the event is actually something that is picked up even on one single locus. So from that point of view, the event is much more specific, but the trend analysis gives you a change or a sort of a trend, which may tell you that, you're going in the wrong direction, change your medications, do surgery, do something else.
especially if it's a younger patient, we take a call that you have to be more aggressive if the trend is not going good.
Yeah. So again, there are no definitions yet, unfortunately. There are no definitions, but what you do know is that, if there's a trend in the VFI of more than 1% per year, the likelihood is that he's going to be a fast progressor. If it's within the 1% per year, then you're likely to say it's maybe age-related that is actually happening over time.
And what is the role of the blue on yellow and the frequency doubling in today's, glaucoma management? And of course, any experience with the VR-based perimetry that is now being introduced, any advantages or benefits of using them?
See, the swap and the FDT unfortunately have fallen a little bit, by the way, because they were all right if you were young and you didn't have any nuclear sclerosis. But the moment you get a little older and you have nuclear sclerosis, it shows up abnormalities that are actually not there. So in glaucoma, most patients tend to be over 55, 60, and as I can say very categorically, you have nuclear sclerosis, and therefore swap and the FTD tend to show us abnormalities which are not there. They're just fallacious. But on the other hand, when you're talking about the virtual reality, I think it's something that still has to be validated. It's very good for surveys, very good for small centers. But all it does is it gives you absolute defects and says that, this is probably the area in which the absolute defect is.
Dr. Ramakrishnan, how many fields would you feel is needed for a baseline understanding?
Yeah, it's a very good question, Chitra. No, it's not the number of fields. Suppose the field correlate with your optic changes. Then I will take it as a reliable even with the first field itself. if I'm not happy, not correlating with the optic nerve changes, I used to repeat the field, not on the same day. I used to ask them to come after 2 weeks, something like that. Usually, second field, about half of the patient, I will do a second field.
I think
It's
more
not
theoretically,
necessary that we should do it in all the cases.
probably more theoretically speaking, we need at least 6 fields over 2 years or similar.
That's fine. That's fine, but it's not possible in our setup. Yeah. Of course, when you repeat the field, when you that depends upon the stage of the disease and also the status of the optic nerve head, and also to find out the progression. Then, depending upon that, we can do once in 6 months, or if it is very advanced, where you want to see the split fixation or something like that, even once in 3 or 4 months, or in the early suspect, something like that.
Murli, you have any other question to ask before we move on to this very important topic?
I have a question for Dr. Parul. That is in moderate and severe glaucoma, how frequently would you be repeating the fields? I mean, like once every 3 months or once every 2 months, one. And the glaucoma progression analysis doesn't give you a progression for the macular and 10-2 fields. So how would you assess progression on macular and 10-2 fields?
Okay. So shall we go, Rohit, shall you go on to the next?
It's an absolute pleasure to have next speaker, Dr. Tanuj, presenting. He is an outstanding speaker, particularly his talks on gonioscopy are extremely illuminating with video presentations. So Dr. Tanuj Dada would be talking on meaningful gonioscopy. Dr. Tanuj, next, please.
Thank you, dear Rohit, for your kind introduction. So, are my slides are visible?
Yes, yes.
Yeah, Dr. Tanuj, go ahead.
So, I have had a lot of passion for doing gonioscopy, and actually, my journey started 15 years back when I got an exceptional resident to work with me. That was Rajamani Murlidhar, and we started documenting. After every round, we used to document the gonio photographs, and so I owe this presentation and whatever my work on gonioscopy to the residents of RP Center, and especially my dear Rajamani Murlidhar. So the basic principle of gonioscopy is that you are not able to view the anterior chamber angle because of the total internal reflection that occurs at the anterior surface of the cornea. The critical angle is 46 degrees. And so basically you need to put a gonioscope to eliminate the optical power of the cornea so that the rays of light can now pass on through to the viewer and you can see the anterior chamber angle. Gonioscopy is basically divided into two broad categories: the direct gonioscopy with the Coipes lenses that we do like examination under anesthesia, and the indirect lenses which we commonly do in the OPD on the slit lamp. The indirect ones have a mirror and they give you an inverted image. This is an example of direct gonioscopy. This is the Coipes lens being used, and this is the Swan-Jacob lens being used for a patient under anesthesia. You can use this directly with the magnification of the microscope, or you can use a handheld slit lamp to view the 360-degree angle with the Coipes or the Swan-Jacob lens. A direct gonioscopy being done in the operation theater. The indirect gonioscopy which we do on the slit lamp is again divided into two broad categories: the schiral type gonioscopy, which involves the use of the Goldman type lenses which have a large diameter of contact, and the corneal type lenses, which includes the Sussman, Posner, Zeiss type lenses, which have a smaller diameter of contact, so they do not require a coupling fluid. So this corneal type gonioscopy is what we call as indentation gonioscopy. You press and push aqueous to open the angle, while with the Goldman type schiral lenses, you do what is known as manipulation gonioscopy. So these are the two techniques we use for slit lamp gonioscopy. So when you put a mirror on the cornea and the angle is not visible due to a steep iris configuration, either you move the mirror towards the angle being viewed or ask the patient to look towards the mirror. So in primary position, the angle appears closed, but when you manipulate, the angle opens up. So this is called manipulative gonioscopy done with the Goldman type lenses to circumvent the increased convexity of the iris. The second type of gonioscopy, so you can see in primary position, the angle structures are not visible, the angle is appearing closed. But when you manipulate the gonioscope, now you can see the tubercular meshwork and the scleral spur has become visible. So that denotes this was an appositional angle closure which opens up on manipulation. Again, angle is appearing closed in the primary position, and on manipulation you can see the angle has opened up. So this is what is being done with the Goldman type lenses. In this situation, you can see on manipulation also the angle has not opened, and this is a synechial angle closure. If the angle doesn't open on manipulation, then you can do indentation gonioscopy. So here you are just pressing the lens on the cornea and pushing aqueous into the anterior chamber angle. So when you do this, if the angle opens up, that means it was appositional closure. If the synechia remain as such, that means the angle is not going to open with pressure. That is a synechial angle closure. That is why you use indentation gonioscopy. And whenever you start gonioscopy, the first important principle is to identify the Schwalbe's line. So you make a 30 or 45-degree angulation of the slit lamp and you see two beams of light. The first beam is from the corneal endothelium and the second beam is from the corneal epithelium. And where these two beams meet, that is the termination of the Descemet's membrane or the Schwalbe's line, the starting point of the angle. So this is an important landmark to identify the Schwalbe's line before you start identifying the angle structures. This is how a normal gonioscopic open angle is visible. So you follow up from the iris, you will see this dark grayish or brownish band, that is a ciliary body band. Above that you have this white zone, that is the scleral spur. Anterior to that is the pigmented trabecular meshwork, then the non-pigmented trabecular meshwork, and the Schwalbe's line. So basically in gonioscopy, you have to identify the scleral spur and the trabecular meshwork. This is the drainage portion of the angle. So if this is visible, that means that the angle is open. The aqueous is able to drain. So first comment on the angle, whether it is open or closed. Secondly, you comment on the configuration of the iris. So this is a steep iris configuration and this is a concave iris configuration. And then you comment on the pigmentation of the angle. So these are three important things to comment: amount of angle opening, convexity of the iris, and angle pigmentation. And a simple way, you don't need to follow any classification. You just draw these three circles, what is known as a goniogram, the Schwalbe's line, the trabecular meshwork, and the scleral spur, and mark out whatever is the pathology. So that is a simple way of reporting gonioscopy by drawing a goniogram. Now, what are the indications of gonioscopy? The primary purpose is to differentiate type of glaucoma, open or closed, primary or secondary, to identify new vessels in the iris, pigmentation of the angle, to look out for post-traumatic changes such as recession, rule out foreign bodies, and a number of diagnostic and therapeutic intervention, because now we are having the minimally invasive glaucoma surgery for which gonioscopy is required. And when you are performing gonioscopy, you can just do a posterior defocus and you can also get a very nice stereoscopic view of the optic nerve head through the gonioscope. So how to perform gonioscopy? You retract the lower lid with a cotton wasp or your finger and insert the gonioscope. This is ideally done in a dark room with a narrow slit which should not cross the pupil. So just withdraw the lower lid and insert this is the Goldman type gonioscope being used, and then you view the angle structures. And the second type of gonioscopy is the Swan-Jacob. Now this is a child of congenital glaucoma, and here you have no angle structure visible because there is an anterior insertion of the iris. So this is the Swan Jacob gonioscopy being done before we start operating a patient of congenital glaucoma. And this is a magnified view. Now you can see it's a completely open angle follow up from the iris. The ciliary body band is visible. Then you have this white zone, scleral spur visible, pigmented part of the trabecular meshwork visible, non-pigmented part, and the Schwalbe's line. So whenever trabecular meshwork and scleral spur is visible, that denotes that patient has got an open angle. So you can see here, first two slides, trabecular meshwork, scleral spur visible. Below two slides, none of the angle structures are visible. So you can see this is a angle closure. This is the open angle. And this is the most important slide of the presentation. You can compare the superior video with the inferior video here. An open angle, trabecular meshwork, scleral spur, ciliary body band visible. Here, a completely closed angle, none of the angle structures are visible. So open angle glaucoma, angle closure glaucoma. So you have to learn to identify the contact of the iris with the trabecular meshwork. Now you can see here, trabecular meshwork is visible, but in some portion, the iris is starting to attach to the trabecular meshwork. So that denotes the development of goniosynechia, and that denotes that patient is going to angle closure. In contrast, young patients, you get a completely different pathology, that is prominent iris processes because of a developmental anomaly. This is a patient of juvenile open angle glaucoma. You have an anterior insertion of the iris onto the trabecular meshwork, causing the obstruction to the aqueous. Congenital glaucoma, featureless angle, only thing we'll get is a very anterior insertion of the iris. So the iris is over the trabecular meshwork due to a developmental anomaly. This is aniridia. You can see why it is a misnomer. There is a rudimentary stump of the iris is present, and atrophic ciliary processes are visible. Aniridia with secondary glaucoma. And this is just a grading of the pigment. You can see with the increase in pigmentation of the angle that can occur with aging, post surgery, post laser. And also, if you get a Krukenberg spindle with a concave iris configuration, this is pathognomic of the pigment dispersion syndrome, uniform dense pigmentation of the trabecular meshwork with the Krukenberg spindle. And this is, of course, at All Issue Medical Sciences, we get a lot of referrals to rule out Wilson's disease. And this is a very nice gonio photograph. You can see the KF ring and this copper deposition on the Decimates membrane that is very nicely visible through the gonioscope. So gonioscopy can be used to identify the KF ring in Wilson's disease. This is a patient of Cogan-Rees syndrome. Here you have very anterior synechia formation because there is an abnormal corneal endothelium, and you have this secondary angle closure occurring. This is unilateral, very anterior synechia formation, and that clinches the diagnosis of a ICE syndrome. This is a patient of a central venous retinal vein occlusion, and you can see the new vessels. These are diffuse, irregular, arborizing vessels crossing the scleral spur. So that is a pathological neovascularization of the anterior chamber angle. Very important thing to do undilated gonioscopy in diabetic patients and vascular occlusions. To identify this, patient requires immediate pan-retinal photocoagulation. And if you get a patient with an injury like a blunt injury, always look at the angle, because these patients can have a irregular widening of the ciliary body band. This is angle recession. This is blood in the angle, and this is the iodialysis. You can see the ciliary process visible. So angle recession is very important. Irregular widening of ciliary body band. These patients can develop glaucoma 10-15 years down the line. And finally, very interesting, you can pick up foreign bodies in the angle. This is an iron foreign body, and this is a glass foreign body in the angle visible. And finally, you must look at the trabeculectomy ostium through the gonioscope. You can see a patent ostium, and here you can see that the iris has gone into the trabeculectomy ostium. And this is, of course, the tube of the Ahmed glaucoma valve visible, and the express shunt implant visible through the gonioscopy. So a lot of uses of gonioscopy, it's must that you should do gonioscopy in daily practice. And from where to read, this is a free educational resource from the World Glaucoma Association. You have a basic courses on gonioscopy, optic nerve, and here you will get all the videos on how to do gonioscopy. So I'll close here. Thank you very much for your kind attention, and thank you, Dr. Chitra Ramurthy, for this kind invitation.
Thank you, Dr. Tanuj. It was a wonderful talk and had us all wrapped in attention. When we talk of gonioscopy, which angle grading system would you advise for the beginners as the most reliable or reproducible?
So I think you should not follow any grading system. What is important is that you draw that circle and report what is the angle structure visible to you in the superior and the inferior quadrant. Number one. Number two, whether the angle opens up on manipulation. Number three, the iris configuration. And number four, the pigmentation of the angle. So it is better to draw the circular diagram and report whatever finding is visible in the clock hours. That is the best method, because if you do grading, the second person who refers the case, he has no idea what you have written 2, 3, 4. So better to write the structure visible on gonioscopy, draw the circle, and then refer the patient.
Going to a clinical question, what would be the thing which pushes primary angle closure glaucoma based on also on the history and in the examination that makes you take a call that you're going to do a PI for that particular patient?
So I think you have asked very vital question. So I think the moment you do gonioscopy and you find that the iris is in contact with the trabeculum meshwork, so that means patient has got a goniosynechiae or a peripheral anterior synechiae. That is the absolute indication of doing a laser iridotomy, because that patient has got primary angle closure. If the patient has an appositional closure, that means the iris is in contact with the trabecular meshwork, but on manipulation is opening. Then you only do PI if there is a strong family history, if patient cannot come for follow-up, or the patient is a diabetic requiring frequent examination and dilatation of the pupil.
Yes. Thank you very much. And Murli, you have any question to ask?
Yes, sir. Thank you for that kind introduction. And I have a couple of questions, sir. One is for a primary angle closure suspect, if you do a laser peripheral iridotomy, there is some widening of the angle. Can this be quantified on gonioscopy? And during follow-up of a patient who has undergone laser peripheral iridotomy, what all would you look for in gonioscopy, or would you rather recommend doing a AIOS-ARC for this patient who has undergone a laser peripheral iridotomy?
See, the once you do a laser iridotomy, definitely the angle opens up, because that was the purpose of the iridotomy, to relieve the pupillary block. But if you have done the iridotomy, you must follow up the patient, because many times iridotomy is small, it may close down. Then again, you can get a rise in pressure. And secondly, with aging, there is an increase in lens diameter, and you can still get residual angle closure or progression of disease despite your iridotomy. So that is why it is essential that you follow up the patient on gonioscopy. And I think if you take a gonio photograph, that is ideal, because then you can follow up the patient over time and see what are the angle changes. And day segment OCT is very good, but it's a very expensive tool, and you have to have expertise in marking the scleral spur. So it's not for every postgraduate that they have access to the anterior segment OCT.
Thank you
So
very
how can
much.
you identify a plateau iris configuration on gonio?
So Murli, you have supplied that photograph of plateau iris. So I think you have a double hump sign and a sine wave configuration. And post iridotomy, the best way is to do the indentation gonioscopy, and then you can identify the bulge in the periphery to the ciliary body. Thank you.
Thank you. Thank you very much, Dr. Tanuj. I think we shall now go on to our next speaker. Our next speaker is our very eminent teacher of excellence, Dr. Ramanjit Sewata. And she is going to be telling us beautifully all that we need to know about the anterior segment OCT interpretation and the technique which would help us further in the diagnosis and management of glaucoma?
I would like to say that I'm trying to share my thing. Has it?
Yes.
Yeah. Okay. All right. I'd like to say that I think Tanuj's talk is the most important one for postgraduates, because that is something that all of us should be doing, ideally in all patients, but definitely those in whom we think there may be glaucoma. Can I be heard?
Yes.
Yes, ma'am, you're visible, audible.
So basically, the reason that we think about an anterior segment OCT today is that it is non-contact as compared to the gonioscopy. It gives us really high resolution images, and it doesn't need Dr. Tanuj to be doing a test. Any technician can do it. So it's an easy non-contact high resolution image, which gives us some indication, both qualitative and quantitative. The qualitative one is to look at the general anterior segment morphology, more specifically at the iris configuration, any iris abnormalities there might be, and of course, most importantly, the iridotrabecular angle. As far as quantitative is concerned, it gives us the biometry of the entire anterior segment in terms of thickness of the cornea, anterior chamber depth, the anterior chamber width, area, volume, anything you like, you can get from this. It specifically looks at angles depending on where you measure the angle. And as I said, it also helps us with the central corneal thickness. But when we think about what are its clinical uses in glaucoma, I think we talked in two general sort of spaces. One is the management of glaucoma, and the second one is how has it helped us in the research in glaucoma. So as far as management is concerned, just like gonioscopy, basically we're looking to see how does it help us in diagnosing different glaucomas. And just a few examples to also say that the whole idea of doing any investigation in glaucoma or a patient with raised IOP is to see what is the cause. Why is the IOP on the higher side? So if you can see this image on the upper left-hand side, this is what a normal anterior chamber would look like. These areas here that I'm pointing to are the scleral spur. This actually is showing us a beautiful trabecular meshwork, and this is what Tanuj was trying to show us as the corneal wedge. So the corneal wedge is actually where the trabecular meshwork starts, and you can see this, and you can see the space of the trabecular meshwork behind it. This is the line joining the two scleral spurs, and by and large, the lens tends to be either behind or just a little bit anterior to that. I will come back to that in a little while. When we actually have the high definition images that are now available with swept source OCT, you can see that the anterior, the entire trabecular meshwork is visible. And there's this little black line over there, which was originally called the trabecular shadow, but has now been labeled the extracanalicular limbal lamina. So this is what I've drawn over here. And if you look at this diagram, you can see the lamina over there. At the same time, you also see what is called the trabecular scoop. That means here we have the scleral spur, and this is the space available for the trabecular meshwork to be sitting on. So going back again, I think the most important the tool we have with anterior segment OCT in glaucoma is to identify the scleral spur. And there are very many ways in which it can be done. I'll talk about a few. One is that you can actually see where the trabecular meshwork ends, and you can see that there's a kind of little point over here. So this is the scleral spur. The other way to do it is to actually see the anterior surface of the ciliary body. If you see the anterior surface of the ciliary body and follow it further up, that is a secondary sort of indicator of where the scleral spur should be. Now, if you look at these images, these are nice and open. On the other hand, you can see this is a much narrower image, but again, you can see the entire trabecular meshwork shown to us in great detail in these high definition images that are now available. So what are our basic aim, as Tanuj said, to start with in gonioscopy? You want to know, is the angle open or is the angle closed? So in the previous one, I showed you an open angle. This is wide open. There is absolutely nothing that is sort of in contact. The iris is not anywhere in contact with the cornea or the trabecular meshwork. And exactly what he said is, you can see the last roll of the iris, the ciliary body, and then you start to see the posterior trabecular meshwork, anterior trabecular meshwork, and the Schwalbe's line. So if we are looking at a narrow angle, and this is what we would say is a narrow angle, this is what we can see clinically. You can use a Van Herrick's, you can use a torch, you can see anything clinically. This is the kind of picture you're likely to get on the anterior segment OCT. And you could, if you like, make it colored. It just looks nicer, but doesn't give us anything extra. So when we actually see these narrow angles, what are we actually aiming to do? We would like to get a measurement of the angle itself. This is from the scleral spur. You mark the scleral spur, and most of the anterior segments will automatically give you what is the angle between the most peripheral part of the cornea and the tangent drawn from the surface of the peripheral iris. You can additionally get an angle opening distance, which can be at 500 microns, at 750 microns from the scleral spur. It again gives you areas that are there in these 500 or 750 microns from the scleral spur. So in all these cases, you actually have to mark the scleral spur. And in these images, you can see it, but in a significant number, it is not so easy to see. Again, it's the angle and then any additional measurements you want to take, which are available. These are not so much of clinical significance. This is really, the angulation is of clinical significance. Anything less than 20 degrees is likely to be occludable or closed. So in primary angle closure disease, you can see that the scleral spur is here. This is the red dot, which is showing us the scleral spur. And you can see how much iridotrabecular contact there is. And in the Cassia machine, you can actually see how extensive the iridocorneal or iridotrabecular contact is. Up to here is the trabecular meshwork. Anything beyond that is the cornea. So you can see extensive synechia that are there, and it tells you what is the extent. In other glaucomas, in congenital glaucoma, you're likely to see a thin iris. You're likely to see abnormal tissue, and you can see the abnormal tissue here in the angle, as was shown on the gonioscopy. You can see patients who have spherophakia, and you can see that there is a secondary angle closure in such eyes. You can see that there are patients in whom there is a synechia which is formed either to the intraocular lens or to the lens itself. And this leads to a secondary bowing of the iris and angle closure. You can get silicone oil, which you can actually see beautifully sort of layering the back of the cornea, and therefore you know it's also layering the entire extent of the trabecular meshwork. In PKs, you can see that there are extensive synechia generally to the host graft junction, and this is the host graft junction, and you can see the iris synechia over here, and therefore you know that this is what's going to be to continue to be there even after you do your management. In aphakic glaucomas, remember, you can have an open angle with aphakic glaucoma because of chronic uveitis and other reasons, or a developmental anomaly that may be there with a congenital cataract. On the other hand, you can have synechia which form to the vitreous face or to the IOL or to a membrane that might be there, and therefore you get a secondary angle closure. So you use this to diagnose glaucomas or the causes of the different glaucomas that are seen. It has helped us greatly in diagnosing the reason why angle closure occurs in a particular eye having primary angle closure disease. I think we've all seen pictures like this, wherein when there's light, there's meiosis and the iris is pulled centrally. The moment the patient goes into the dark, you can see the bowing of the iris and the angle closure. So if we actually look at different causes, the first thing you have to say is that an occludable angle would be one which is less than 20 degrees. So the angle formed by the most peripheral cornea and the iris, if it's less than 20 degrees, is likely to go into closure. A plateau iris is one where you have a flat iris which suddenly dips in the periphery. Because this is an anterior segment OCT, you cannot see that the ciliary body processes are actually pushing up the peripheral iris. This is a controversial one, and I think we saw this diagram on the right side earlier, where if you join the two scleral spurs, the lens is generally at or just slightly ahead of that. As compared to that, a lot of angle closure eyes may have much thicker corneas, and it's thicker lenses. And it's the reason why the lens is thick is because the width of the limbus, that means from limbus to limbus, it's much smaller, and therefore the lens is allowed to become thicker. And here you can see that the lens is actually more than 1/3 of the distance between the a line joining the posterior cornea to the line joining two scleral spurs. So this is seen probably in about 10 to 15% of patients with primary angle closure glaucoma. Plateau iris is seen in probably about 5 to 10% of primary angle closure disease. And please remember that relative pupillary block is the most important cause. The second thing, as Dr. Tanuj was saying, is we want to be able to differentiate apposition from actual synechia. So if you look at these pictures, you can see I've drawn a white arrow and I've drawn a red arrow, and you can see that the white arrow is actually just a bowing of the iris, and you cannot see the extreme periphery, and there is still a very narrow recess which is open. This, when looked at gonioscopically, very often looks like apposition. On the other hand, when you have actual synechia, you can see that the surrounding tissue, that means the cornea, also is showing us fibrotic changes over there. And the anterior segment OCT helps us to actually differentiate these two much better than we possibly could on gonioscopy. The ITC index I've already spoken about, but basically just to reiterate, what it actually does is it helps us to know how much of the iris is actually touching the trabecular meshwork. And this is a patient with primary angle closure, and you can see there's just a little bit of the iris which is actually touching the trabecular meshwork in both eyes. All right. And this is in the with the patient in the dark, and this is with the patient in light, and you can see the difference that there is. This is a patient with primary angle closure glaucoma, and you can see again, please, if you look at the iris touching the cornea, you can see the associated sclerosis, fibrosis that is in the angle and in the cornea and the trabecular meshwork as well. And if you look at the ITC, you can see almost 360 degrees of the iris is touching, definitely touching the trabecular meshwork and probably into the cornea. So the ITC index has helped us to say what is the extent of the pass, and therefore if the extent of the pass tells us what is the damage to the trabecular meshwork. If we want to evaluate the anterior chamber in opaque corneas, one, as I've already said, is in post-PK glaucomas. Here we have a patient who is a Peters anomaly, and this was an anterior segment. It was actually an UBM, but you can do a similar one with an anterior segment OCT, which actually shows you what is happening. And post-surgery, you can see the clearing that is seen. So I'm sorry, in children, we find it a little difficult to do an AIOS-OCT, but it was just to tell you that this evaluation can be done. Intraoperative assistance these days is quite useful, especially when we are doing blebs like this, which need to be revised. It actually tells you what the bleb looks like and helps you to remove just the epithelium so that what is left is a functioning bleb. It can also be used in surgery itself, and it has been said that if we use an intraoperative anterior segment OCT, we can determine the thickness of our superficial flap and also the size of the ostium. Finally, I think to evaluate therapy is quite important in management. It tells us whether the iridotomy is patent or not. It tells us what is happening to eyes once an iridotomy is done. So you can see over here, again, this is the ITC, and you can see only about sort of 20 degrees of the iris is actually touching the trabecular meshwork. This is a patient with primary angle closure glaucoma, and you can see the angle is narrow, but not showing us any synechia. After an iridotomy, this is the iridotomy that has been done, you can see the decrease in the iridocorneal touch that was there. Okay, so you can see that there is the iridotomy has helped. Similarly, if you were to see this patient, you can see that again, after the iridotomy, there's absolutely no iridocorneal touch that is seen, even though you could see it earlier before the iridotomy was done. In primary angle closure glaucoma also, as I said, we can see almost 360 degrees having a significant iridocorneal contact. And once the iridotomy is done, you can see that even that has decreased significantly. Anything that was above the trabecular meshwork has come down. You can see the difference pre and post iridotomy. So an iridotomy definitely seems to help. And this helps us to evaluate the therapy and say that in such an eye, possibly medical therapy may be a good option and surgery may not be required. What about research? I think, as I said, it's helped us to understand pathogenesis. It's, I'm sorry, we're still going on with the filtering bleb at the moment. The other thing is to actually grade a filtering bleb, and you can see it tells us what is the thickness of the wall of the bleb. It tells us whether there are any cysts. It also tells us what is the size of the ostium that we have made. And these photographs are 1 year, 2 years, 3 years after surgery. So you can see that these kind of cystic spaces probably lead to a dysesthetic bleb. They may be leading to lower IOPs, but the patient is going to be quite uncomfortable. This is a much more sort of gradual sort of rise in the contour of the bleb and is less likely to cause problems as far as the patient is concerned. What we also see is that you can see post-operative complications that may occur when we're doing trabeculotomies. This is a Descemet's membrane tear, sometimes even with trabeculectomy. Drainage devices can be seen very clearly. You can see the AGV tubes over here. And if you put it into the pars plana, you can see the tube coming behind the iris. You can see an express shunt, and because it's metallic, you can see the edges much more clearly. It tells you that in this particular instance, the express shunt has been blocked by fibrosis. Once you do a bleb revision, this is the pre-operative picture of the anterior segment OCT and the color photograph. And you can see it after a bleb revision has been done 4 years after the surgery. So you can see there's still a filtering bleb, and you can see that the patient had an IOP of 10 to 12 millimeters. So coming to the research, beyond the parameters that I told you about, there are many other parameters that are being evaluated. And as I said, the angle is what we are most often measuring, but you can measure anything else in the anterior chamber using the various tools available, including the area, the volume of the anterior chamber, the area, the volume of the iris, when it is constricted, when it is dilated. So all of these are giving us a good indication of what is happening inside the eye physiologically. So all these measurements can be done and should be taken care of in research. So some of the anterior segment biomarkers that have been suggested for glaucoma after all this research is that in congenital glaucoma, you can see that there is a maldevelopment of Schlemm's canal. It may not be there at all. There may be an associated membrane, very similar to the so-called Barkan's membrane seen. In angle closure disease, people are now talking about the anterior chamber width and area and the iris area being more predictive of which eye is actually going into angle closure. Finally, the trabecular area and morphology has now become so well visible that it's almost like doing a histopath of the angle. So I would like to say that, anterior segment OCT is not essential in the clinical management of glaucoma, but it is helping us in many ways to understand more of the pathology and the management or better management of whatever we are doing, because it gives us pre-operative pictures and post-operative parameters that actually help us say, this is the surgery I did, this is what I ended with. The IOP is not as low as I want it to be because the bleb is probably not showing me as many microcysts as I would like. So you can change your surgery depending on what you see on the anterior segment OCT. It is also suggested that you can use an anterior segment OCT at 1 month after surgery, and that would help you to decide, no, this patient needs additional mitomycin C or it needs additional steroids, or you can stop the steroids, or you can do some needling for the bleb so that you get good long-term results with your trabeculectomy. So I'd just like to thank everybody who was involved in this presentation. Thank you.
Thank you very much, Dr. Ramanjit. Many of the questions I had wanted to ask have been answered in your presentation. But again, like just taking an example, maybe a young patient with an aniridia where you cannot do a gonioscopy, there are certain areas where anterior segment OCT actually does help, like rather than just being a secondary tool, even in the primary diagnosis of an angle closure or cross.
Yes, absolutely. I think the most important place is when there is a corneal edema or there's corneal opacification. At that point in time, you don't know what you're going into. You know the pressure is high. You know the baby has a corneal edema, and for years we used to just go into the eye saying, "I hope there's no aniridia there." But now I think we can actually figure out before we get in whether it's an aniridic patient, whether there's an anterior segment dysgenesis, whether the angle is showing us very severe problems, and in things like post PK, post adherent leukomas and things like that. Again, it helps us to say, there is a adherence between the iris and the cornea in this quadrant. I should avoid that quadrant and probably do my surgery or any filtering surgery away from any of the already existing adhesions.
Thank you very much, Dr. Ramanjit. Dr. Rohit, can you go on to the next speaker? I think we'll be running short of time and there are many more topics to be discussed.
We now move on to the disc evaluation, and the first talk on interpretation of disc photographs will be by Dr. Devan Tuli, one of the most outstanding dynamic glaucoma specialists with a super way of presenting. I'm sure we'll all love his outstanding presentations. Dr. Devan Tuli, please.
Yeah, thanks a lot, Rohit, and I'll just start with this. So just wanted to say that the residents and mainly the courses for the residents have a habit of writing just the cup straight away. But that is not correct. You should actually, if you ask me, the most important thing in the disc evaluation, it is the neuroretinal rim. So keep that in mind. It's a neuroretinal rim which is so important. And once you have focal, please look at the highlighting I'll show you. So once you have a focal loss, then that's known as notching, which I'll show you. And only when you have generalized loss of the rim, then you get what you write most commonly is the cup. So evaluation of the cup, again, we'll talk about. The vertical one is more important. Loss of RNFL, disc hemorrhage, and asymmetry. This is not the complete list, but the most important ones to take home message. So the first thing actually to look at is the disc size and the margin. And this is very easy. Usually the size of the disc, as we know, is about 1.5 millimeters. And this can be measured with the slit lamp tools, measuring tools which are available. So once you've done the disc size, the margin and the size, then the next thing to look at is the rim. So if you have the disc, margin, the size, and the rim dimensions, then the third thing based on the disc and the rim, then you calculate the cup. So cup actually is the third thing to look at. The vertical one is most important one in glaucoma. Keep that in mind, more than horizontal. And also in the rim, we look at the color. Third thing is the RNFL, like I said, the parapapillary atrophy, PPA in short, is the beta zone, which is more important. I'll come to that later. The hemorrhages, which may be hidden and subtle, so look for them carefully. The blood vessels, and of course, the asymmetry. So the ways to examine the disc, I think the course is on imaging, so the stress is on fundus photographs. But believe me, you can do the direct ophthalmoscope, but actually, if you ask me which one to buy, the lens to buy, it should be a 90D or a 70-80 lens. 90D is the advantages. You can look through a small size pupil also. So if there is one choice, 90D is the best. So direct ophthalmoscope is to be discouraged. Some of us are actually in the habit of using only the indirect. So both these are to be discouraged. Then I've already said 90D, 70D lenses, and the fundus photographs are now possible also with the cell phone adapters. So that is so easy to do, and there is no reason not to record the fundus photograph Yes, even the fundus cameras, which are used for the retina, can be used for this. But I am actually, if because it is lot of the, it's an AIOS presentation and the whole of India is watching it, I'm not going to ask you to depend on all this. Just record it with a disk diagram that can be easily learned. What you see, just scribble in your notes, and that is the one thing to do. This I have tried to do with the PowerPoint. You can see the disk margin, the cup, the rim, and we've shown an RNFL defect and also the hemorrhage here. So this is, I think, very important to remember. Yes, this is the probably an important tool. You can record it, you can show to the patient, it's more convincing to the patient at times, and follow up. But don't miss out on the disc drawing, most important. So the optic disc size, I told you 1.5 millimeter is the normal one. And you can see when you compare with the small disc, this one is a small one, and the large one, in which, because in the large disc, the choriospinal canal is large. That is why it can be a large cup, which may not be. This looks like glaucomatous, but actually this is just a large cup in a large disc size. So this may not be abnormal, but I'm very concerned as a glaucoma person. I'm very concerned with the small. See, it's appearing to be a normal size cupping. The rim is appearing okay, but the space is not there in small optic nerves for the cup to enlarge. So very concerned with this because this may be actually pathological and appearing as normal. So both ways, keep that in mind. And that is why the disc size is very important to record. The OCT, which Sharmila will talk about, actually, if you ask me, one of the biggest advantages of the OCT is it tells you the disc size in actual numbers. So that is important, but if you don't have it, you can do it, like I said, with this. So the rim is it's the thickest inferiorly, as seen here, followed by superior, the nasal and the temporal, which becomes the isn't rule, but it's not always satisfied. Remember what I'm going to tell you next. In the notching of the rim, the question asked is, what is the commonest site for the notching of the rim in most glaucoma situations? The answer is the photograph on the right, this one. So it's actually the inferior part. To be very precise, it is the inferotemporal part in which you commonly see the thinning of the rim or notching of the rim, as we call it, as shown in this photograph. And if you remember what I showed you in the previous picture, that normally the rim is thickest, it's widest in the inferior part. And in glaucoma, that usually the widest part, which is usually the widest part in glaucoma, is becoming the thin. And it's most commonly in that area. So that is why when you're looking at to differentiate a glaucoma optic neuropathy versus a non-glaucoma optic neuropathy, please look at the inferior part of the disc, and inferior thinning of the rim is an important pathognomic or diagnostic feature. It helps you in the differential diagnosis also. It is next followed, this photograph is showing you, it is in the superior part is the next common. So these two, actually inferior and superior, are the widest, thickest parts, and they are the ones which are commonly affected in glaucoma. Keeping this in mind, remember this, the next photograph, that the vertical enlargement of the cup, or if I say it in the other way around, vertical thinning of the rim is very, very diagnostic of glaucoma. So you can see here that in this picture, both the inferior and the superior part are thinned out. The nasal and temporal are also thin, but they are still maintained. So vertical enlargement is diagnostic. In advanced cupping, I think this is something which we've learned from ma'am, Dr. Ramanji, that if you look at the bending of the blood vessels here, I'm asking you to look at this photograph. If you look at the bending of the vessels right here, this is the actual margin of the cup. So I'll remove that just to give you that. So the bending of the vessels defines the contour of the cup. But if you look at the actual, if you look at the pallor, the size of the cup by the pallor, it is appearing smaller. But the bending of the vessel is where the contour of the cup is. and you should actually be writing both. You should write that by contour, it is the cup is this much, and by pallor, it is this much. If you see this much of discrepancy. So this, in this photograph, which I've already shown you, this photograph, if you ask me the cupping here vertical, it's almost going to 0.85 to 9 vertically. But if you look at the pallor size, just this pallor, then it appears smaller. So keep this in mind. The bending of the vessels is an important feature to look for. And same here, this is an advanced cupping as can be seen. But I just wanted to show this, that the rim has thinned out in all dimensions, inferior, superior, nasal, and temporal. So the next thing we look at is the color of the rim and pallor. So pallor can be seen in angle closure glaucomas, but if you see pallor like this, then you should always consider a non-glaucoma optic neuropathy also. So rule that out, keep the differential of glaucoma lower down the list, rule out a non-glaucoma optic neuropathy. It could be a brain occupying lesion or so on and so forth, and ischemic optic neuropathy, rule that out, and then consider an angle closure. You can have a picture like this of the rim pallor. Then the RNFL thing, see, you can, there is a sector defect in the color photograph also, the fundus photo. But it is much better seen in this one. You can see the defect with the red-free photograph. Now, again, we are depending on the fundus photograph a lot because that is the theme of this symposium. But this you can also see, the red-free filter, with the red-free filter of the slit lamp, make a habit, use a 78D lens, which gives you a more zoomed up picture, flip to the red-free filter, and you will see these sector defects, which are so classical. Now, I'll remind you that the thinning of the rim, the commonest site for that in glaucoma was the inferior part, followed by inferotemporal. This next thing I'm going to tell you now is the commonest site for these sector RNFL defects in glaucoma, the commonest site for that is again inferior, and to be very precise, it is inferotemporal. So keep that in mind. What I told you earlier, in glaucoma, inferior part of the nerve is showing changes. Please think of glaucoma. So you can have an obvious RNFL defect with the red-free photograph. And look at this. I'll just point out, see, this is the same thing. The inferotemporal wedge shape defect in another patient, very well seen with the red-free photograph or the red-free filter. So the diffuse RNFL loss, then once you have a sector defect, in contrast, you can see it nicely, which I showed you in the previous slide. But look at this. The best, see, the normal RNFL is seen here in between the blood vessels with these bright striations. Also seen in this, with the red-free photograph, the bright striations in the vicinity of the blood vessels. And you can see in the glaucoma, these striations in between the blood vessels are missing. So that becomes more of a feature of diffuse RNFL loss, which is when it is there all 360 degrees. And the same thing can be seen. The striations are lost here in between the blood vessels in the red-free photograph. So make a habit of this. I know a lot of our residents are not doing this. It's very easy to look at RNFL defects and RNFL loss. You don't need fundus photographs. Yes, with the slit lamp also possible. Now, the parapapillary atrophy is becoming of a lot of importance in the last 1 decade because what we have now defined, there are other zones also now defined, but just for easier comprehension today, the alpha and the beta zone. And which one is more important in glaucoma? Please remember it is the beta zone. And the beta zone, why? Because actually what it is, beta zone reflects the atrophy of the deeper layers of the retina, which are in the vicinity of the choroid, the deeper layers of the retina. That is what the beta zone is. And why it is important, beta zone more than alpha zone, is because it is more common in glaucomatous eyes. The alpha can be seen also in normal eyes. So that is why we pay more attention to the beta zone. And because beta zone is so important in glaucoma, I have a mnemonic to teach you. So the mnemonic to learn beta zone is the 3 B's, B's as in B. 1 B is the beta, the name. The second B is because it is dangerous, it is more likely to be glaucoma. So the second B becomes beware. And the third one It is the one closer to the disc. As you can see, margin, it is closer to the disc margin. The alpha one is away from the disc margin. So the third B is besides the disc. So the third B of beta zone is besides. So the three B's are beta, beware, and besides. Remember this, the deeper atrophy such that the choriocapillaris become easy. Now that was in the previous picture. This was a more diffuse one, but I'll show you the once you have it in the early stages. The common location, I'll remind you, for the notching of the rim was inferior. Also for the RNFL defects was inferior. Now, the third thing to remember for your exams is even the typical location, the common location for the beta zone is the common one in glaucoma is again the inferior part or the inferotemporal part. In fact, so much so that a large beta zone will correspond to a thinner rim. It will correspond to a corresponding sector RNFL defect. So all these are interrelated, inferotemporal part common, inferior part common. Then the hemorrhages can be obvious or they can be hidden. They can be subtle, like I told you. So they mean that the glaucoma process is active. That means you may need to lower the pressure further. And this one is, at the disc margin. So it may be hidden in the rim, the color of the rim, if it is pink and healthy. So this one is actually, I'll just remove that arrow. So you can see the disc hemorrhage, this one. Then it can be on the blood vessel, just on the contour of the blood vessel. So it requires careful examination. Or it could be as small as this one. The arrow is already there. So they require careful examination. And again, the disc hemorrhage is the commonest location for that also. I don't have to tell you the answer. Is again inferior. It is inferotemporal. So please remember this. And if you remember all that, then the last two slides of my presentation become easier. The disc anomalies become easier. If you remember the sequence, I asked you, I'll just come back to this. I asked you to look at the sequence. Start with the disc margin and the size, and keep that in mind. If you do that, then a staphyloma. See, actually the disc margin is this one. All this is the neighboring staphyloma. So if you looked at if you keep in mind the first point which I taught you is to look at the disc margin, then this differential, disc anomaly becomes easier to solve. Also, we have said the disc margin. See, it's like a tilted disc. And you can see a part of the disc is maldeveloped. So if you track the disc margin, which was the first point I taught you, then you know this is not a normal disc. So you look for a congenital anomaly or think of a congenital anomaly. It could be a tilted disc, which could actually manifest with a field defect also. But these are not abnormal. They can still have glaucoma, but they are not abnormal. Then the rim part. Come to the second point. The rim was the thickest inferior and superior. In fact, we said that the temporal rim is not much affected, or it may be affected only in advanced glaucoma. In this, which appears to be an optic pit, you can see the thinning is only in the temporal part next to the macula. But the inferior part of this is still, the inferior rim is still thick, the superior rim is still thick, it's still maintained. So if you keep that rule of mind that inferior is affected most, then you know this is temporal was affected. You have to think of something else. It could still be glaucoma, but think of something else. If you look at it carefully, this was an optic pit. So these, if you keep that sequence in mind, and this was a sequence. Disc margin, I'll quickly repeat that. And Chitra ma'am, this is the last slide I have. The disc margin, always look for that. Then the disc size. Then you define the rim dimensions in all the four quadrants. Then look at the rim color. Then the RNFL defect, followed by the parapapillary atrophy, the beta zone. And then you look for the blood vessels and the disc hemorrhages if there are any. And lastly, you look at the asymmetry. So these are the important ones. This is not the comprehensive list. There are some soft signs which I purposely avoided just to keep the duration of the talk which was given to me. This is a classical glaucoma picture and there's a large parapapillary atrophy all around is typical of glaucoma. And based on all this is what you have the DDLS scale, and this is available on the internet. I've taken in fact from the ResearchGate site, and it is based on what I've just taught you, the 6 or 7 important points. So there is a table which you can see, and table is based on those points. Thank you very much to Dr. Chitra, Rohit, and AIOS for including me in this. Sunil, can you just stop the screen share, please? Thank you.
Thank you very much, Dr. Devan. You had described it in great detail. I would have had some questions for you, but I think we are running late. And since you have discussed every point so well, I think the questions have to be missed now.
No problem. Thank you.
Yeah. We'll go on to our next speaker, Dr. Sharmila, a senior glaucoma consultant from Arvind Eye Hospital from the Madurai branch. She is going to discuss OCT of the optic disc and its relevance in glaucoma. On to you, Dr. Sharmila. Look forward to learning a lot more from you.
Good evening, madam. Thank you very much for the opportunity. And having said that, Dr. Devan had given so much information about clinical evaluation of the optic disc. There may be a question, are we really going to look into imaging? But definitely imaging does have a role. So let me just go about that. So, yeah, so we all know that glaucoma is a chronic progressive optic neuropathy where structural changes happen before functional damage is seen. And in order to pick up those structural changes early, that is in the pre-perimetric glaucoma stage, where one may not be able to appreciate the disc damage or a field change, one may have to rely on imaging modalities such as the OCT. The OCT is basically a non-contact, non-invasive imaging technology, which is on the principle of optical interference. It is similar to that of an ultrasound, but it just uses a light instead of the sound waves. So it quantifies the tissues by measuring the intensity and the echo time delay of the light from the tissues. So we all know that there has been several evolutions which has happened in the OCT. So first it started off with the time domain, and then it is a spectral domain, and now it is a swept source OCT. So the recent modalities of OCT, they have a better resolution, faster scanning speed, 3-dimensional acquisition of images, they're highly reproducible, they have a better segmentation algorithms, and they're very useful for detecting progression. I'm very much convinced in using an OCT because it gives so much of information. One, you can entirely scan the optic nerve head. Number two, you can do an RNFL analysis. Number three, you can even do a macular ganglion cell analysis. All comes in a single particular machine. But however, we need to choose the program depending upon the basic pathology of the patient. For example, if the patient has got a very small disc, it is better to go for an RNFL analysis because many of the optic disc parameters could be missed by a normal optic disc scan. Secondly, if there is a macular ganglion analysis which you're going to do, you have to make sure that there is no macular pathology before you're going to do the macular ganglion cell analysis. So you can choose a program according to the basic pathology the patient has or the basic requirement of the patient. So first is the optic nerve head analysis. So it is basically done by a cube, which is 4 × 4 millimeter measurements using standard reference points such as the Brooks membrane opening and the retinal pigment epithelium. You can make out the disc margin, the cup area. It gives enormous information about the optic nerve head. For example, it gives the vertical integrated rim area, the horizontal integrated rim area, the disc area, the cup area, the horizontal cup disc ratio, the cup volume, etc. The BMO minimum rim width. This is a very important anatomical landmark, and it is a very recent modality to detect early glaucoma. So Brooks membrane opening, which is seen here as a red dot here, that's very important because it is a termination of the Brooks membrane around the optic nerve head. And it is through this opening, most of the axons exit the eye, and it is the outermost edge of the neural tissue at the level of the optic disc. So this is a spectralis ONH printout. Where you get the Brooks membrane opening minimum rim width measurements, and these are taken at 12 locations around the optic disc. And just like an RNFL profile, this is also given in a descent graph, that is temporal superior nasal infratemporal graph, and each parameter is color-coded. So it's very easy to interpret it, but we should predominantly not go only by the colors. Rather, you have to look at the measurements, you have to look at the thickness at each quadrant. So this is basically an RNFL scan of a Cirrus HD OCT machine. So just like how we would do a visual field printout reading, we'll have to go in a stepwise manner. This first you have to look at the patient information. So the patient information is really very important, and most important to that is the signal strength. There is something here which is known as a signal strength, and here you have a denominator of 10. So anything more than 6 is acceptable. And then you have the second scale. What you have to see is the parameter table, which is given in the center. This is in the Cirrus OCT printout. Here you have the right eye, left eye measurements, and you have the average RNFL thickness. You have the RNFL symmetry between the two eyes, the rim area, the disc area, the average cup disc ratio, the vertical cup disc ratio, and the cup volume. Again, these are all color coded. And then you have the RNFL thickness map, which is basically the raw data. And you don't have to remember the colors because there is a scale which is adjacent to this thickness map. And with this scale, you can make out whether the RNFL is thicker or thinner. And then you have the RNFL deviation map. This is basically showing how much is this patient deviating from the age-matched normals. And here you can see that there are 3 rings. The inner ring is the cup margin, the outer ring is the disc margin, and then you have the RNFL measurement circle. So the NRR, which is actually the distance between the cup margin and the disc margin, is displayed here. And you have it for the right eye and the left eye as a straight line and a dotted line. It predominantly falls in the green shade. I'll come to the colors a little later. And then you have the RNFL thickness, which is again from the calculation circle using the around the disc margin. And here again, it is for the right eye and the left eye. And below that, you have the sector-wise and quadrant-wise and the sector-wise or the clockwise distribution of the RNFL thickness. And then you have 3 images on either side, which is actually a tomogram images, which is the horizontal tomogram or the vertical tomogram. It basically shows that the machine has aligned to the RNFL layers, that is the superior or the inferior. And it also is very important to identify any segmentation errors or truncation. And then there is lastly is a circular tomogram, which shows any vitreoretinal interface problems. And then coming to the colors, gray is basically more than normal. That is, these are above normal, and white is the thickest retinal nerve fiber layer. Green is the normal range. That is 5 to 95% of the population fall in the green range. And then yellow is between 1 to 5%, and red is the thinnest, where only less than 1% of the population will fall in the red zone. And similar to that, we have a Spectralis OCT printout, a little different from that of the Cirrus OCT. You have to look at the parameters again, like the patient data. And here the quality scan is in a score of 0 to 40. So if you see anything more than 20, it is considered to be a good scan. And then you have the fundus image, which is basically the infrared fundus image, which shows the BMO centroid. That is, it is an axis which is marked between the fovea and the Brooks membrane opening. And this value is between 16 to 7. So anything beyond that is considered to be abnormal. And then you have the RNFL profile image, which is shown below here. And then based on this RNFL profile, again, there is an RNFL thickness profile, which is color coded. This is for the right eye and the left eye. And then in between both these, the right and the left eye, you have an asymmetry between the right and the left eye in the quadrant wise. And then you have the classification. That is, the global parameter will be the center circle. And then you have the superior quadrants, supratemporal, supranasal, the temporal, the nasal, infratemporal, and infranasal. So you have in each quadrant what is the asymmetry in measurements between the right and the left eye. Again, these are also color coded, and here predominantly you have only 3 colors. The green is in the normal range, the yellow is the borderline, and the red is in the outside normal limit range. And then we have also a macular analysis. We all know that more than 50% of the retinal ganglion cells are located in the macula, and RGC loss happened very early in this region. So it is very useful for detecting early glaucoma, and this should be considered as a part of a routine comprehensive glaucoma evaluation, especially in early glaucoma. So this is a ganglion cell analysis printout of Cirrus OCT. Here you see again the signal strength. The signal strength is something which is really, really important. If it is less than 6, we'll have to consider repeating the scan. And then this is a thickness map, which is again color coded. Don't have to remember the colors. There is a scale here. You see the scale and see the colors corresponding to it. And then here is the deviation map, which shows how it is different from the age matched controls. And then you have the right eye, again a sector wise distribution, the left eye, And then in the middle, you have this very important table here, which shows the average ganglion cell layer and inner plexiform layer thickness for the right eye and the left eye, and also the minimum thickness which is seen. And here below is a circle, the tomogram, which shows that the image is passed through the fovea. That is, the fovea should be present to show that it is a well-centered image. And it also helps us to identify any macular pathologies. That was with the cirrus OCT, and the similar to that we have in the spectralis OCT, where you have a posterior pole asymmetry analysis. And this is basically done with an 8x8 grid, and then you have again color coding which is given at the site. And here, interestingly, we have a right and left asymmetry which is calculated. Gray areas are areas which shows a reduce in RNFL thickness. And then you also have a hemisphere asymmetry, that is within the same eye. You have a superior to inferior asymmetry or the inferior to superior asymmetry which is calculated. Predominantly, all these dark areas are the areas where there are reduced RNFL thickness. And here you can see that in this image, both the superior and both the eyes show a superior arcuate fibers which are reduced. Although it is very easy to interpret, although it is very simple, we do have to understand that there are a lot of artifacts that can be involved in this. So one could be because of the operator, second it could be because of the patient, or because of the device. So as I told earlier, one thing is the signal strength. So one has to concentrate on that. And in a spectralis, more than 20 is good. And in a cirrus, it is more than 6 is supposed to be a good scan. And then this is what I was mentioning about the segmentation or the truncation. Here you can see that the RNFL layers are not exactly determined by the machine. So because of this, there will be a lot of bizarre readings, and you may sometimes get it as false positive because it is not in the measurement circle. And then even with an improper placement of the RNFL circle, here you can see in the left eye that it is not equidistant around the optic disc margin. You can see that the ring is placed closer in the superior quadrant here and very wider here. So this may give false measurements or a false positive values. And then so we have to very much be very clear about where the ring is, and this has to be identified early and had to be corrected. After you correct, you see that there is a disappearance in the red value which is seen without correction. So one has to look into it. And there may be also factors related to the patient, like the pupil diameter. The pupil has to be well dilated. There should be no media opacities. Make sure that the patient does not have any dry eye, and blink reflex should be avoided. Floaters should also be kept in mind. And there may be also a lot of motion artifacts. So one has to look into those areas as well before interpreting it. So blink artifact here, the machine is actually not doing the measurement, and so there is no data to interpret, so it is shown as red. And once you correct for that, you repeat the measurement and you get a good normal values. Similarly, a motion artifact could be identified by the presence of bending of the vessels, which you see here. So once you do that, again, there is a discontinuity here, and then there are areas which are showing here as a dip in the RNFL thickness, which falls in the red area. So once you correct for that, then the values become normal. And there may be also some floaters like the vase ring or the PVDs, which can come in the area of measurements. And so that can also cause false positive results. And then there are also device-related artifacts, because we have to make sure that the patient is not having any microsaccades, and so make sure that they're fixing at the target. And also this cannot differentiate, Preop glaucomatous from an ischemic optic neuropathy or a hemicentral retinal vein occlusions. There may be also certain deposits on the lenses because of touching of the lens, which may be seen as such media opacities. So one has to clean the lens before taking the measurements. The most important thing here is misinterpretation artifacts. There may be red disease. Basically, these patients may not be having a real disease, but they may be interpreted as red disease. And then there is a green disease. For example, they may be having normal values, but actually there may be a focal defect which is hidden inside. So one has to be very careful, and you have to understand how to interpret this. So for example, if there is a dense PSCC or a myopia of -14 diopter, it doesn't fall in the normative data range. And so then you get a false positive results. So we'll have to look into it with a clinical correlation, and also after removing the cataract, we'll have to redo the scan and then do the base analysis. And again, whenever there is a presence of a myelinated nerve fiber or a vitreoretinal traction, this is also shown as a green disease because of the increase in thickness. And here, if you see, this is a normal printout. If you see by just looking at the colors, it appears like it is a normal patient. But however, you have to carefully look at this RNFL profile. Here you see that there is a dip here in the inferior area. So when you do a macular scan, you can pick it up in the macular scan showing infratemporal decrease in the RNFL thickness. So it's very important to identify focal defects very carefully by looking at the RNFL profile. We all know that we have the normative database only for patients more than 18 years. So those who are less than 18 years, there won't be any color coding. And also, if you look at these machines, these are all basically developed with the normative databases of European descent or American descent. And here we have only 1% of Indian population contributing to that. So that has to be also kept in mind. And when you read a printout of an advanced glaucoma, it is really very difficult because it will be usually there'll be a floor effect. So you won't be able to, the machine will not be able to identify any other loss, residual glial tissue, including blood vessels. So in case of advanced glaucoma, one has to rely on other parameters like the Humphrey field analyzer or the octopus field analysis rather than looking into the OCT for progression. In case of moderate glaucoma, this is a patient who have a very good signal.
Conclude, sorry.
Yes, madam. I've just finished, madam. This is a moderate glaucoma patient. And here you see that there is an early glaucoma. Again, there is a macular ganglion cell, which you can pick it up. So importantly, you have to differentiate neurological. And again, it follows the vertical meridian. That's what I wanted to say here. So the tips and tricks to interpret OCT is always you check at the quality of the scan, identify whether it is a glaucomatous patient or not glaucomatous, differentiate true or false positives, always correlate it with the clinical finding, consider artifacts on interpretation, and also you should consider the normal aging loss which can happen. So I would say that we could never interpret OCT alone in isolation. You have to go in hand with the clinical evaluation, differentiate normal from abnormal, and also understand that there may be a true positive or a false positive. Thank you for patience.
Thank you very much for a very wonderful talk, Dr. Sharmila. Dr. Mandal, you could share your screen while I ask just one question to Dr. Sharmila. Between the ganglion cell complex analysis and the RNFL analysis, which is more critical to detect glaucoma?
I would say if it's an early glaucoma, I would go for a ganglion cell analysis. If it is a moderate glaucoma where you want to just look at the progression, I would go for an RNFL analysis.
Okay, thank you. There are a lot more questions I could have asked. I think we'll have to do it at a later date. Our next speaker is Dr. Anil Mandal, an expert in glaucoma surgery in the pediatric age group of global standing from LVPI, Hyderabad, who's going to teach us explicitly about trabeculotomy and trabeculectomy.
Yeah.
On to you, Dr. Mandal.
Yeah, thank you, madam. And for my presentation, I have edited a video for about 9.5 minutes, so respecting time.
Yes.
At the outset, I would like to express my profound gratitude to my teachers, Professor N.N. Sood, Dr. Harish Agarwal, and Dr. Ramanjit Siota, who were my mentors at All India Institute of Medical Sciences when I was doing my senior residency in the year 1987, 88, 89. So during presentation, my mind goes back and memory goes back to the year about 32 to 33 years back. So in the video, I would like to present exploration of Slem's canal and primary combined trabeculotomy and trabeculectomy for developmental glaucoma. Exploring Slem's canal is one of the key surgical steps for doing external trabeculotomy. Anatomy of the limbal region must be carefully identified before one can proceed to explore the Slem's canal to do the trabeculotomy. You can see here a radial incision is given on the external aspect of the scleral spar to cut open the superficial wall of the Slem's canal. And this particular step, although not part of the surgical technique of trabeculotomy, is just to explore the Slem's canal, how by external dissection, beautifully we can explore the Slem's canal on either side of the radial incision, which was given to cut open the superficial wall of the Slem's canal. What essentially we are seeing here is deroofing of the Slem's canal, and at one point of time it was an ideal surgical technique for glaucoma. Now you can see what we have done in this segment is superficial wall of the Slem's canal has been removed. What follows now is the surgical technique of primary combined trabeculotomy and trabeculectomy. Here we are confirming that yes, that Slem's canal has been dissected properly. Combined trabeculotomy, trabeculectomy is performed under a partial thickness scleral flap, limbus based, and the delineation is done to mark, and under higher magnification, a gradually deepening incision is given to cut the superficial, to inside the superficial wall of the Slem's canal. And at the end point, there will be slow ooze of aqueous, as is evident here. And in higher magnification, you can see the inner glistening wall of the Slem's canal, nothing but trabecular meshwork. Once the Slem's canal is explored, this instrument called external trabeculotome, Harm's trabeculotome, is introduced. The lower prong goes inside the Slem's canal and is rotated to create a continuity between the Slem's canal and the anterior chamber in that segment. When performed on each side of the radial incision, approximately 110 to 120 degree of the trabecular meshwork is taken care of. Next step is seen here, removal of the deeper block to complete the trabeculectomy and an iridectomy. Here we are doing little irrigation aspiration to remove the clot or the bleeding which accumulated over the iris surface, just to do very clean surgery. The superficial scleral flap is closed back with a suture, 10 nylon suture. I used to perform the closure by 3 suture. After 10 years of my work, we used to close by a single apical suture, and the triangular scleral flap is closed. 1128 eyes of 653 patients operated over a 21-year period by me in this LV Prasad Eye Institute was analyzed recently, and you can see the survival curve. Over a period of time, the success rate decreased, and it is bound to happen. Success rate of 93.4% at the end of second year decreased to almost 70% at the end of 10th year. Just to tell you that this success rate is without any anti-glaucoma medication and first surgery success rate. Snell's visual acuity of was available in 51% of the patient, and 27% had got normal visual acuity. Patients who were operated by us as a primary surgery, success rate is better, and patients who had clear cornea had better surgical outcome. In patients where surgery was performed on congenital or true congenital onset within 1 month of birth, the success rate is relatively poorer compared to the infantile and juvenile onset glaucoma. Here is a patient, compare and contrast acute hydrops with infantile glaucoma, and the lower picture tells us the normal clarity achieved, and this picture was taken 6 months after the surgical technique of primary combined trabeculotomy trabeculectomy. In the same patient, the successive picture will show, just compare and contrast, preoperative, 2 weeks, 2 months, and 6 months postoperative appearance of the child. And you can see the Habs stripe, which is there. And here is the appearance of the child. Cornea, left eye was involved eye, cornea is totally clear. the right eye was not involved. Primary combined trabeculotomy is very safe and effective in the management of congenital, infantile, and juvenile onset developmental glaucoma. And at this point, I just wanted to present the just to show the same technique once again on a 17-day-old child. The trabeculotomy probe, the lower prong is introduced and upper prong gives us guide where the lower prong is, being introduced into the Slem's canal. You can see clearly on the other side, once approximately 70 to 80% of the probe is inside the Slem's canal, it is rotated so that the lower prong, which is inside the canal, will disrupt the trabecular meshwork and will create a continuity between the anterior chamber and that segment of the Slem's canal. This is the trabeculotomy part of the operation, and then the trabeculectomy is done. This is the child on whom the surgical technique was performed. 17 days. This child completed about 25 years of follow-up, done pharmacy degree, and is doing her job. Is to come for regular follow-up. Just see, this child was operated for congenital glaucoma. Just observe the behavior of the child. Nice to see that a third month operation was done. The child is doing so beautifully. Thank you. I complete my presentation here.
Thank you very much, Dr. Mandal. I think the secret of your success is also the emotional attachment which you have to your profession in a very major way. Just one question before we go on to our last speaker.
Yes.
Is there a corneal diameter cutoff beyond which you feel that the trabeculotomy is unlikely to work?
That's the advantage. Very important question. According to Barkan, corneal diameter 14 millimeter or more, goniotomy should not be attempted. But external trabeculotomy I have performed in corneal diameter 14, 15, 16 millimeter. In most of the situation, if we do the anatomical landmarks identification properly, it is possible to do external trabeculotomy. And if it is difficult, then anyway, you are combining with trabeculectomy. The trabeculectomy part of the operation should work. That's the advantage of combined trabeculotomy and trabeculectomy.
Thank you very much, doctor. Thank you.
Thank you.
Last speaker of the session, and an amazing woman who is presently the Honorary Secretary of GSI, is Dr. Chandrima Paul, who's going to concentrate on surgical treatment, teaching of trabeculectomy. On to you, Dr. Chandrima.
Thank you.
Thank you very much, Dr. Chitra and AIOS for this invite. It is indeed a pleasure to be here on board with stalwarts. So I'll go right away my presentation. That's
Not one, get two.
Could others be on
One
mute,
is not
please?
correct. Two.
Could others be on mute? Yes, Dr. Singh.
Preventing complications and taking you through it. So glaucoma surgery has traditionally been all about efficacy, and serious safety issues have promoted evolutionary improvements. So surgical therapy for glaucoma is usually resorted to in case of failure of conservative treatments. Trabeculectomy was described as early as 1968. To date, the gold standard for glaucoma surgery is trabeculectomy. Wound healing at the conjunctival and episcleral plane, that's the limiting factor for the success of trabeculectomy. Antifibrotics like 5-fluorouracil and mitomycin C have been widely used for wound modulation to improve the surgical success. But however, they have been a little costly to us in terms of post-operative complications. So as they say, old is gold, old wine is the best to taste, old horse to ride, and old friends to trust. So also trabeculectomy, as I told you, is the most popular form of glaucoma filtration surgery and remains the gold standard for surgical reduction of the intraocular pressure. So the advantage of trabeculectomy over prior full thickness filtration procedure was the concept of guarded scleral flap, which reduced the rate of complications related to overfiltration. And in 1980, modifications to increase the efficacy and reduce complications like suture lysis, modifications of flap, superior wound closure, use of antifibrotic agents, as I told you, have contributed greatly to the success of trabeculectomy. The decision to operate depends on the patient who is unable to use the medicine, ocular intolerance to the drops, unable to reach the target intraocular pressure, and when there is documented progression. For surgery, the advantages are potentially unlimited reduction of intraocular pressure, long-term cost of laser, etc. is saved, little or no impact on quality of life. Well, that is a little bit with a question mark, and independence of patient compliance. The disadvantages of surgery, however, are the complications, both intra and post-operative and late post-operative, loss of control of IOP over time, about 10% reduction every year, and the need for additional medications if and when they are required. So the modifications in technique have come with the scleral, with the square flap, the triangular flap, the semicircular flap, the trapezoid flap, and a lot of these have changed over the years, the fornix-based, the limbus-based, the releasable sutures, but in the long run, I feel it's that which works best in your hands that you should stick to. Wound healing, most common cause of failure is scarring in filtering bleb. So we use antifibrotic agents, like I told you. But here we must remember one thing, that trabeculectomy is a surgery against nature. In all other surgeries, we actually pray for healing, but here we pray for not healing. So that's the difference with trabeculectomy, and using the antifibrotic agents these are the cases where we use it in lower age groups, aphakic or pseudophakic eyes, neovascular glaucoma. And with that, I move on to trabeculectomy is an excellent procedure when it succeeds, and to ensure that it does, you've got to avoid many landmines along the way. That's conjunctival buttonholes, over and under filtration, and hemorrhage. And over the years, we've seen that surgeons do well and could do better when performing this procedure, and in came the Moorfield Safe Surgery system of trabeculectomy. So I have no financial interest out here, but if you instill a drop of brimonidine into your conjunctival sac just before you start operating, it could help you see your way through the bleeding blood vessels. Next, we move on to the operating steps. So I'll start with the Wechsel fluid dissection. Here, actually, you have to be sure that you have a non-tooth forceps, and that's where you just slightly move your bud over the conjunctiva to release it so that you have a freely moving conjunctiva. And this is the incision that I generally use. I do a fornix-based trabeculectomy, but that's not what you should practice if you are not comfortable. You should go with the surgery that you are comfortable with. And this is something I have designed for using the mitomycin. We put the conjunctiva on stretch, so a wide pocket for applying the antimetabolite sponge underneath the conjunctiva. I generally use a concentration of either 0.2 or 0.4 mg per ml for 2 minutes. And That's a no-touch technique for putting in the mitomycin. And then, of course, all of us, as you know, we wash the area with Ringer's lactate once you've distilled water, once you've finished with your mitomycin. Next comes one of the most important steps, that is the scleral flap or horizontal incision parallel to the limbus. Dissecting a partial thickness scleral pocket is made. The two sides of the incision are cut with specially designed scissors. I call them the scleral scissors. I designed the scissors as well, and they actually reach just up to, just falling short of the limbus. So we have a wider surface area for the movement of the aqueous. And next we have the punching of the ostium. So that's a non-shelved incision at the sclerolimbal junction, and I generally punch it out with the Kelly's punch, or I sometimes also just use the venous scissor. And iridectomy is has to be done and well, and not partial but complete iridectomy, so that generally done with the scissors parallel to the iris plane. And it's advisable to use releasable sutures. So that's a releasable suture that you see there. So it's relatively simple. Just take it in through the limbus, in through the conjunctiva, and through the scleral flap onto the inner lip. And after 4 throws, just take out that loop, and that's your releasable suture. And it helps you titrate the IOP post-operatively. And the conjunctival closure is done with a round-bodied needle, not a cutting needle. Make sure that you don't injure the conjunctiva when you are sewing it up. So with that, you will finish off with trabeculectomy, just a small clip on phacotrabeculectomy, because that's what we do more often nowadays. So I always prefer a double site phacotrabeculectomy, but I sit at the superior end, but I do not shift my position. After making the flap, all I do is just extend my hand a little bit and do the rhexis and the phacoemulsification. As you see out there, the flap is done superiorly, and then that's where I enter. And I finish my rhexis from the side of the flap and the hydro, and then the phaco probe through that incision as well. And this is ologen. This is a relatively older surgery of mine when I did triangular flaps. So it's important to do a releasable suture when you're using ologen, so that helps you titrate the intraocular pressure post-operatively. And it's relatively simple. Just after completing your trabeculectomy, that's the ologen. Ologen comes in 2 sizes, 6 millimeter diameter or 12 millimeter diameter. So that's a 6 millimeter diameter one. And you just place it over your scleral flap and you close your conjunctiva. So trabeculectomy provides a non-physiologic route for aqueous outflow, and complications may occur despite the best efforts of the surgeon. Timely detection and management of these complications is vital for a good surgical outcome. So these complications can be divided into peroperative and post-operative. So here I'll show you one of the dreaded complications. That's the torn flap, which happened. Just look at that. I punch out the ostium and see what happens. I've pulled out the flap. But not to panic, complete your surgery. That's the iridectomy done, and then suture the flap back. And that's how you place it right where it should be, and suture the flap back so that it creates the normal scleral flap that we want in trabeculectomy. And once you've done that, it's fine, and there is no need to panic. But then when it does happen, you do get panicky. So that is it. Actually, the flap is sutured back, and it's almost as good as a normal scleral flap. And this is one of the dreaded complications that can happen. It happened to me while doing a live surgery. So look at that. This was a myopic eye, and I didn't see the patient before surgery because it was at a workshop. And look what I do. The sclera was relatively thin, and there it goes. So again, not to panic. So all you have to do is basically close up that wound completely and start afresh. So I closed that and then I started afresh, and I was actually doing a in this surgery, and I did my surgery just as it was planned. And that is it, basically. So, peroperative surgical pearls are considered topical or bulbar anesthesia. Never use tooth forceps to handle the conjunctiva. Aim for watertight conjunctival closure. Lower high preoperative IOP. I always use mannitol 100 ml before surgery and never leave the operating room with an unclosed leak. So a successful trabeculectomy is a stable surgical fistula. The one thing required to keep a fistula patent is flow, the principal, and most challenging complication is scarring, and prevention is always vastly preferable to cure. So a little bit on the prevention and management of the complications. So intraoperative, as I told you, you can have buttonhole of the conjunctival flap. So gentle handling is required with non-tooth forceps and suturing with tenonylin in a figure of 8 if it does happen. So episcleral hemorrhage, gentle and sustained pressure, light cautery, use of viscoelastic, choroidal effusion, slow release of the AC is very important. And there, of course, using mannitol preoperatively is very important. Preoperative mannitol, counseling, suprachoroidal multiple incisions to drain the fluid. Vitreous loss during iridectomy due to rupture of the lens annules and the anterior hyaloid membrane. So post-operative complications, you can have hypotony, which is the commonest complication, and flat anterior chamber. Conjunctival defects can be noted with Cyril sign. You can put a pressure bandage or suture that up, or you can also use a bandage contact lens or a scleral shell tamponade. Excessive filtration, again, large bleb and shallow AC. Tamponading the bleb is important. AC formation with either a high molecular weight viscoelastic or a gas bubble. And serous choroidal detachment, use of oral and topical steroids, cycloplegics, drainage of fluid, and AC formation with viscoelastics to raise intraocular pressure. The late complications are leaking bleb, especially in MMC augmented treb, failing bleb with raised intraocular pressure. You can massage the bleb, argon laser suture lysis, start anti-glaucoma medications, needling of the bleb using 5-FU or mitomycin. Encapsulated blebs, digital massage, and you can start anti-glaucoma medications and needling. Cataract formation is one of the complications of trabeculectomy, and of course blebitis, where you can have endophthalmitis also, leak and pain. So that's it. And with that, I thank you for your attention. And that's the team actually who puts up with all my acrobatics in the theater. Thank you very much.
Thank you very much, Dr. Chandrima. That was so good, and it took us through all the very essential steps, and I'm sure the postgraduates would have learned a lot, why all of us did learn too. Just one question before we conclude. Murli, would you want to take that question? 1 or 2 questions, maybe we are at the end of it, it's okay. Murli?
Yes, madam. Yes, madam. So, madam, how do you titrate the tightness of the releasable suture?
The releasable suture actually post-operatively generally we, you mean that while doing its surgery?
Like how tight should the releasable suture be? And,
I think it should not actually pull on the cornea. It should be just right that it creates no pull on the cornea basically at the operation table.
No, the releasable suture, the main purpose is to prevent the complication. So in the initial post-operative period, especially during surgery, it should be tight enough. That's why you have to put 4 loops. 3 loops, so it will give way. So 4 loops, so you have to both throws. It should be tight. So that it won't allow any access to flow out.
Madam, is there any standard, sir, sir, is there any standard size of the ostium that you should be?
Ostium, no, it's what Chandrima has shown is good, but usually what I do is I do triangular flap, and my ostium flap is 4x4 always, and ostium is 2 millimeter, 2 by 2. So I will take a little larger ostium, including the little bit of cornea and the sclera and trabecular meshwork, all these things, and part of this, up to where the gray zone meets the white zone. Till then I used to take. Not the number of bite, what we are reviewing is more important.
How do you decide on the mitomycin dosage and duration, Dr. Ramakrishnan?
Mitomycin, I normally use almost all the cases of tuberculotomy, but that too also is not rule of thumb. It's depending upon the various factors. Suppose primary surgeries versus repeat filter, and also age of the patient. And another important thing is the type of glaucoma. There is a primary glaucoma, a secondary glaucomas, and third, fourth one is the how long the patient is on anti-glaucoma medication. Suppose the patient is on anti-glaucoma medication, especially prostaglandins and all these things, then your concentration should be little more, especially 0.4 milligram per ml for about 3 to 4 minutes. So all it depends upon the various factors. Then only we can decide about the dosing of the mitomycin. If it is a primary filter and virgin conjunctiva not exposed to any anti-glaucoma medication, 0.2 milligram per ml for about 2 minutes is more than sufficient.
Sir, how soon would you remove the releasable suture? Like if on day one the bleb is flat and the chamber is quite deep, I mean, how soon can you remove the releasable suture?
Yeah. At least you have to wait for a week. Suppose if you remove it immediately, then your chances of going for cellular chamber, and sometimes we had one expulsive hemorrhage, supracortical hemorrhage, sudden decompression, chances are more. So we have to be very careful and always put additional scleral flap suture on either side. Suppose if you are doing a triangular scleral flap, some people they do two releasable on side and one at the fixed at the apex, depends on the surgeon's choice. But never do remove the suture in the first post-operative. First, wait for a week.
And what is the concept of teaching Moorfield safe surgery system to resident trainees?
Yeah, of course, that's very, very important because previously our students are mostly limbal based. So in that case, we will be having a localized blab, and another thing what they have to understand is the ring of steel phenomena, because there's a formation of a strong fibrovascular band which obstructs the flow of aqueous from the anterior limbal to the posterior of the space. So there comes your Moorfields because we were doing, so after that only the phonics base become more common. It's not phonics base, but how long you are extending posteriorly. You have to do undermining of the conjunctiva on either side of the rectus and put the medicine much more posteriorly, either 2 or 3 sponges which are touching the pre-margin of the conjunctiva. So in that case, you won't, most certainly you won't see the height of the bleb. The bleb will be very diffuse and you will have a very good control of the intraocular pressure. Yes, Moorfield's technique is very much useful, especially this undermining of the conjunctiva and also the keeping the mitomycin sponge in the posterior aspect of the one clear pocket.
It gives a larger surface area basically for their
Yeah, that's correct. Yeah.
Any other questions before we conclude? Murli?
Yes, madam. I mean, sir, what is your experience with the other antimetabolites like Avastin and?
Avastin we have tried in a few number of cases, but the results are not that great when compared to mitomycin. And of course, 5FU also we have tried either sponge, even the injection post-operatively, intraoperatively and post-operatively. But it's not as cumbersome for the patient. It's injection is painful and also corneal complications are more with the 5FU. And that too, the results are not that great. But one thing is vitamin is good, but we should know how to use it, how long you should use it, what concentration, and what are the complications you can expect. All these things you have to keep in mind. Then only we have to go in with the mitomycin. Yes. Mitomycin is the best.
What is the current role of NPDS, non-penetrating glaucoma?
Of course, now we have, especially I do in cases with advanced glaucoma, where you have a fear of macular washout, Suppose a fine curve, more far 9 curve with the macular split phenomena. In that case, I used to do non-penetrative. Usually, the deep sclerectomy with visco canalectomy on either side. There's a commonly done non-penetrating filtering surgery. Yes, yeah. Only not in all cases. In myopes, where suppose a high myopes where the sclera is very thin, you will not be able to use antimetabolite because of fear of scleral thinning and hypotony, other related complications. In that case also, deep sclerectomy will be used.
The AIMS group had come up, I have a question for Dr. Anil. The AIMS group had come up with a 360-degree trabeculotomy with a light pipe.
Yeah, but we have, I don't have any experience except I have tried some with the Prolin suture because we don't have that fiber optic probe and all these things. So with 6-Prolin, we have tried in adult juvenile open glaucoma. In some we were able to, but we're not as a routine. Not as a routine. Yeah.
Thank you very much. I think we need to conclude. Glaucoma is such a vast subject. There's so much to hear and talk. I do hope we keep coming back with more webinars and glaucoma, which would be of great benefit to the audience. Needless to say, it has been one amazing webinar with a difference. And my very deep felt thanks to the most eminent panel and our most respected speakers. My thanks are due to, of course, Mr. Kripal and the admin team of AIOS, Sai and Manjula from Numerotech, Mr. Sunil, our webinar admin. My thanks to my dear ARC team, a source of huge energy and positivity. Our thanks to Sun Pharma and Mr. Nagmohan, who desired to set off a series of greatly valued webinars for the postgraduates, which would happen over the next few months. And finally, and most importantly, my thanks to my dear attendees. And I do wish and hope that we were truly of value today. Thank you, one and all. Thank you very much. Thanks a lot. Each talk was so amazing.
Thank you.
Good. Thank you. Good night.
Thank you, ma'am.
Thank you. Thank you.
Thank you, everybody. Wonderful,
today.
wonderful. The glaucoma part was sensational. I think the postgraduates would have really loved it.
Time
one of the best.
Speakers have done a wonderful job.
Yes, yes.
Thank
you.
Thank
We
you,
load all of these on the ARC website, so I'm sure people can always access of this as and when they want. So.
Yeah. Chandrima ma'am's talk was the best.
Thank you.
What did you say?
You're very kind.
I said the last, save the best for the last. The last was the best.
Yes.